I think it's a great segue to what we did a second ago with all the pontification and confabulation. We're going to get somebody to put data and his perspective on this. So Jason's going to share with us wide neck aneurysm, a lot of options, when I use what.
All right, it's that stage of the meeting. The crowds are dwindling. All right. Okay, thanks again, Ricardo. I'll make a start. And as you said, this will have some segue on from the discussion we were having before lunch. So these are my disclosures again, for those who missed them the first time around. So this talk, I guess I'll talk a little about what I consider to be a wide-necked aneurysm to start with. I'll have a little bit of discussion about convergent and divergent technology, talk about adapting one's strategy to the particular situation you find yourself in with a particular aneurysm, and give some case examples. So before I kick off, I've been asked to talk about when I use what, and that is when I use what. So this is a purely personal experience, anecdotal, and for the purposes of this discussion, I'm going to pretend that open surgery doesn't exist for aneurysms. So when we talk about a wide-necked aneurysm, we really need to ask what's the significance of labeling something wide-necked. And really, there are two reasons we think about this. One, it really predicts the need for an assist device if we're treating the aneurysm, and it also, to some extent, predicts the risk of recurrence because the neck is possibly not as well controlled as it is if it's a narrow neck. And of course, there's angiographic definitions, there's aspect ratio, there's neck width, which may or may not have some meaning in some clinical contexts. But there's also a more practical definition. And from my point of view, I consider a broad-necked aneurysm or a wide-necked aneurysm to be one that I can't get a coil into. But I also put in that same bracket of aneurysms that I can't get a catheter in without an assist device, because they're difficult as well. And I mean aneurysms like this that are offset onto a branch with a difficult angulated neck, because often these require an assist, even though the neck itself would appear to be on the surface of it quite favourable. So practically speaking, I use both approaches. I look at the width of the neck, I look at the aspect ratio of the aneurysm, but I also look at how difficult I think it might be to get in, and I do some measurements. But broadly speaking, the necks of aneurysms fall into a few categories. There's the ones that are more or less circumferential with a fusiform type pattern. And these ones require a local vessel reconstruction. So just getting the neck of these is often not enough because there isn't much of a neck. You actually need to rebuild the vessel in that local segment. Some aneurysms have more of a longitudinally wide fish mouth type appearance with a long neck along the axis of the vessel. And these often require support of an intrasaccular construct, whether it be coils or a web or similar. And there are some that are both circumferential around the vessel and long. And these can occur at bifurcations or in the paraclinoid segment, for example, where you might need a segmental reconstruction. Now, when I'm treating any aneurysm, but particularly wide-necked aneurysms, I think it's important that everyone, that we have a plan A, a plan B, and a plan C, and be prepared to adapt your strategy to the case at hand. And vessels, to me, are a little bit like marriage. You know, they're a little bit different once you're in them. So you need to be prepared to change and adapt once you start treating your aneurysm. But in general, I'd always favour a simple approach over a complex approach. I'll always prefer to do something with a device that I'm familiar with rather than something that I'm unfamiliar with. Of course, I'll always try and do something that's durable rather than less durable for the patient. And if I adhere to those principles, generally speaking, I'll end up with something that's safer rather than riskier. So just to diverge a bit onto this discussion about convergent and divergent technology, I've given a lecture similar to this at other meetings, but we'll all remember from our biology days something like this, the Linnaean chart of evolution and the rapid explosion of organisms during the Cambrian explosion. And we've seen something similar. We had our primordial slime back in the 90s with the evolution of the detachable coil. And then we went through a series of new devices coming out quite quickly after that. We had some temporary neck bridges in the form of balloons. We had some permanent ones in the form of early stents. And even the intrasaccular devices started to evolve. We had bioactive coils, we had gel coils, we had even liquids for a time we used in aneurysms. And the intrasaccular devices have really kind of converged or evolved into these devices that we see today. The temporary neck bridges, we've got balloons, of course, in various shapes, sizes and forms. And we've even got balloon-like stents or stent-like balloons, crossover type devices, whichever way you want to think of it. And the stents themselves have diverged into a multitude of different devices, some which are very niche and designed specifically for tricky bifurcations, others that are braided and others are laser cut. So there's a wide variety of devices. And in all, what that means is we've got over 20 devices that we can use for any particular broad-necked aneurysm, which, I come from quite a high volume centre, but that leaves even me feeling a bit like Livingston in the jungle at times. I'm spoiled for choice, and often it's hard to know what the right thing to do is. So that really comes down to a discussion a bit about experience, and this is what we were talking about before lunch. Experience, it's all very well to do 50 aneurysms, but if you're using 50 different techniques, do you actually have experience? So I think it's important to put some numbers around that. And where I come from, we've got about 40 neurointerventionists in the country. That's going to expand by about a factor of half to 2/3 by 2025. But when you do the maths and look at wide-necked aneurysms, in effect, we're looking at people treating about 20 wide-necked aneurysms each per year in Australia. Now, some will be higher than that in the high-volume centres, some will be lower. But the question then becomes, is it safe to use 10 or 20 devices to treat 10 or 20 aneurysms? And this will have some bearing on the later discussion. So to make procedures safer, we can do a few things. We can increase case numbers, which, unless we embark on rapid immigration is going to be a problem. We can't really just increase case numbers. We can limit operator numbers, and we've seen how effective that is here in the US. We can improve the device ease of use, and the companies do a great job with that, but that has its problems as well. But possibly most importantly, industry can make devices multi-purpose or very widely applicable. So things like the dual lumen balloons, where we can put a liquid or a coil, do a test occlusion, we can do a lot of different things with these devices. So in general, in my practice, I try wherever possible to use multi-purpose and flexible devices over the niche devices, so that I get a lot of experience with 2 or 3 products rather than a little bit of experience with 20. So this is not going to be a discussion about every single product you can use in a wide-necked aneurysm, but I don't have experience with most of them because I've got a very narrow range of devices that I use in almost all cases. So back to the discussion about adapting to our circumstances. This really applies not just to the aneurysm, but to a few things about the patient as well. But the first thing is, of course, is the aneurysm ruptured or unruptured? And obviously the goals are different. So priority 1 in a ruptured aneurysm is to stop the aneurysm from rebleeding. Whereas in the unruptured case, your first priority really is to have no complications. So you've got to do absolutely the safest procedure possible in the unruptured setting. And obviously, when you're talking about ruptured and unruptured aneurysms, the options are slightly different in that there's a slight steering away from stents and flow diverters in ruptured aneurysms, whereas you have a full range of kit at your disposal with the unruptured aneurysms. Location of the aneurysm also has a bearing. For example, sidewall aneurysms will tend to be less favourable for things like the web. Bifurcation aneurysms will tend to be less favourable for flow diverters in some cases. And whether the aneurysm is proximal in the circulation or distal in the circulation will also have some bearing in that using bigger catheters to get into smaller vessels is potentially more risky. What about the patient? Well, obviously in an older patient, patients with comorbidities, these guys will have a lower tolerance for anaesthetics and for complicated procedures. And often we're not so worried about durability in an older patient. We're more worried about protecting the dome of the aneurysm rather than getting a perfect angiographic result. And of course, in older patients with a limited lifespan, long-term antiplatelet use is less of an issue. In younger patients, durability is perhaps more important. Long-term antiplatelets can be an issue, particularly in young women who can have terrible menstrual issues with the second agent. And social factors come more into play in younger patients. Often they've got children, they've got family milestones coming up, and it's important to get them through their treatment and rehabilitation with that in mind. So just a couple of examples of patient-focused care. We'll come back to this case, but it's a 72-year-old woman, incidental MCA aneurysm. She's got mild airway disease, and she's got a past history of peptic ulcer, and but she's otherwise well. So she's probably got a 10 to 15-year life expectancy. She's very anxious about her aneurysm. But in her, maybe we don't treat at all, but it's a bit irregular, and she's very anxious. But the priorities, if we are going to treat, will be to protect that dome and those little daughter loculi. And because of her peptic ulcer disease, we don't want to give her any antiplatelets, which from an endovascular point of view may be a problem. It's about 9-10 millimeters. Yeah. This other example is a 44-year-old man. He's a meth user. The day before I treated him, I found out he's the father of one of my son's school friends, which is very thankful to my wife for telling me that at 10 o'clock the night before I treated him. His aneurysm had grown from 2 to 7 millimeters in 2 years. So, this guy's got some social issues, but the priorities here are to protect him. And obviously he's going to be a compliance issue with his meth use. So again, we want to avoid antiplatelets. And this is a terribly difficult endovascular case with that origin off the anterior temporal artery. But again, for the purposes of this discussion, we're pretending open surgery does not exist. So my approach when I'm dealing with these patients, if it's a ruptured aneurysm, of course, I'll straight coil or balloon coil wherever it's possible. I will use web for suitable cases, but as per the discussion before lunch, I do have reservations about the device. I'll use it if there's very difficult branch access for a balloon, and if there's a nice straight access for the delivery system. But I think there's a discrepancy between how easy the device is to push out the end of a catheter and how easy it is to judge where and when you should be using it and how to size it and where it should be used. And as per my earlier talk, if it's an appropriate case and it's really untreatable by other means, I'll use a pipe shield and aspirin. So just an example, 76-year-old lady, not in terrific health, WFNS2, she's got a wide neck basilar tip aneurysm. It's not a perfect angiographic result. There's only really 2 angiograms because it was all done under 1 inflation with 4 coils, but that's enough to get her through probably for the rest of her life without too many worries. So it's just a simple balloon coiling. This one I showed in my earlier talk. This is a 56-year-old guy with a really horrible blowout of the back wall of his carotid. He got a pipeline shield and aspirin. So we're tailoring our treatment to both the aneurysm and the clinical status and needs of the patient. With unruptured aneurysms, it's a little more complicated. Obviously, sidewall aneurysms tend to lend themselves more to flow diversion. We generally use pipeline as our go-to for the proximal vessels, and we use Silk Vista Baby for the distal vessels. So it goes through a 17 catheter, so it's a very nice low profile and easy to deliver system. For aneurysms of bifurcations, we err towards stent and coil. We haven't really looked seriously at the web as a durable device for that indication, but obviously time will tell. We generally use the Leo Baby at bifurcations. We don't tend to use laser cut stents alone. The recurrence rate's really not acceptable in our view. For T or Y stent constructs, though, we will use a laser cut stent like the Atlas into one branch, but we'll always use a braid in the other, either the Leo Baby or the Silk Vista Baby. Just touching on our bifurcation aneurysms and braided stents, we actually first got access to them in 2011 after we'd had a few recurrences with the laser cut stents. And we decided to put in an ethics proposal to collect our data prospectively, which we did, collected the usual stuff. And our fellows published this is their second paper on this. This is our long-term follow-up of this cohort, came out in Janus last year. And to summarize, I won't go through each of the figures, but we had very low clinical and technical morbidity. Only 2 patients had any neurological disability at all at 18 months. We saw, interestingly, improved aneurysm occlusion over time. So whereas only about 50% had complete occlusion at the time of treatment, 97% had complete occlusion by 3 years, which is probably reflective of the flow diverting or flow alteration by the braid at the aneurysm neck. We also had very good durability at bifurcations, so 94% occluded by beyond 3 years, and all of them really safely occluded. The remainder are all Roman-Roy 1 at 3 years. There's an example of a T-stent construct. It's a 44-year-old guy, smoker, a bit unreliable, but a nice guy. Got his T-stent, got his coils, and you can see his 30-month follow-up there at the bottom right. Very nice and durable result. He's had an MR recently, which I don't have. It was on paper, but it's still durable at 5 years. 64-year-old T-stent construct, 2 Leo babies, and again, the 18-month, very durable result there. This is a case I did at Link, in fact, in 2016. There was some discussion whether I should have used a flow diverter here, but this is a case, nice case of tailoring it to the patient's needs. So it's a giant basilar aneurysm. She'd ruptured in 97 and had attempted surgery at the time. She had a couple of clips there, but she sustained a perforator injury. She's been wheelchair bound since, but she's independent. The priorities here for me, you know, I'm the guy who's got to see her, not the people in the room at Link. My priority is to avoid any further perforator injury because she's got one arm that works and she's fiercely independent. So there was some discussion about flow diverter, but obviously, you know, even though we use it in the posterior circulation in Australia, there is a slightly higher risk of perforator injury using a flow diverter rather than a simple braid. So I elected to put a Leo baby in coils. And this is a nice example where you can see in the middle picture, I deliberately left a little bit at the base of the aneurysm. I wasn't overly concerned about chasing that, having with our experience with the device. And sure enough, at 18 months, you can see that that's completely occluded and she's got no residuum there. This is a 42-year-old lady. So this was shortly after we got access to the Atlas stent. And this seemed to be a good candidate for a Y stent using the Atlas, and that's what we did. So you can see when I say we, remember my pronouns. So there's two Atlas stents in there and a pretty nice coiling. The catheter was a bit jammed in there and we couldn't really get that bottom pocket, but I wasn't overly concerned with that based on our experience with the braids. We thought that would probably close. And that was 1 month post-treatment on the left. And on the right, when she came back to me with her MR, you can see a big flow void at the medial edge of the coil mass and pretty florid edema in her white matter and at the front of her peduncle. So I was a bit worried about that, and she was off prasugrel at the time. So I took her to angio, and sure enough, she's got, you know, significant decoherence of the coil mass, and she's got regrowth. You know, it's not coil compaction; it's growth of the aneurysm in that interval. So I took her back, and I put a 17 catheter round into that contralateral A2, and my thinking was repack and put a braided stent in because we know from our experience that the braids will work. So we put the braid in and repacked it, and you can see on the left her second procedure MR and on the right the post, and you can see the flow void at the edge is gone and the edema is resolving already. So we still have up our sleeve a flow diverter if we really want down the track, but I think the braid will do the job. So not too long after I treated her, and you know, this lady came along with worsening left temporal headaches and this big aneurysm, and she was very keen to have this treated endovascularly, and to be honest, I was quite keen to treat it endovascularly. It looked interesting to me. The difficulty obviously was going to be where that arrow is, the access to that M2 outlet inferiorly. So the plan we put together was to access it around the world with a catheter, take the slack out of the catheter. I'm sure we've all done that. I call it the toilet paper technique, a little jerk on the catheter. You get one piece of toilet paper rather than the whole thing. It seems to work quite well. Deploy an Atlas as the first limb of the Y into the inferior division. Then put the catheter back in because my intention was to use a Silk Vista baby as the second limb. Because I really wanted this to be gone. It doesn't show on the 2Ds, but the aneurysm at the back is very broad. And then to reaccess with the second catheter into the M2, the superior M2, deliver the Silk baby, and then coil. And just to show you the access, it was really pretty straightforward. The whole procedure took about 40 minutes. So there's the access into that M2 out there. I'm not sure how well this projects. It's usually pretty visible. You can see the Silk Vista here, part deployed, and you can just see it wasting a bit as it comes through the Atlas about there. Not sure if you can see it there. So the Silk Vista is just coming out there. That's the construct on the Dyna-CT or after the stent deployment. On the right, you can see the final coiling result. That little loculus down the bottom is part of the same aneurysm. Coils just wouldn't go into it, but I suspect that will go away with the flow diverter. But she's only about 3 weeks out, 6 weeks out now, so I haven't got a follow-up yet. This is an interesting lady, 66. She had a subarachnoid in Croatia when she was visiting her relatives there. And she was lost to follow-up for 2 years and then came to see me when she returned to Sydney. And she was found to have 2 new aneurysms at that follow-up, this tiny little P1 and then a little pica there on the left. And I don't know about you, but I felt that P1 would be a nightmare to treat endovascularly. And I thought the pica might be easy to coil, but then I took it to try and coil it, and it would not accept a coil. Everything was falling everywhere, into the pica, into the vert. It was just impossible. So I thought an approach with the Silk Vista Baby into that P1 would be appropriate. And you can see the positioning of the Silk Vista. The back end of the stent is about here, about to be pushed out of the catheter, just there. And when we deploy it, you can see how flush it just shortens right up to that P1 origin and sits nicely across there. And then turned our attention to the pica aneurysm, and it actually proved impossible to get into the pica from below, from the left. So we switched to the right and came from the right down the pica from right to left, and then delivered the Silk Vista Baby there. So you can see it going from narrow and constrained in the pica to nominal diameter in the vert. And this is the follow-up at 6 months. So the aneurysms, both aneurysms are gone, and the stents are nicely patent. So back to our original lady, the 72-year-old, the one where we can't give her antiplatelets or don't want to because of peptic ulcer disease. You can see what I'm doing here. I hate to say it, but I'm putting a web in this thing. You know, I'm going to get shot here in this room for saying that. But you know, there really aren't many options, in all honesty, for a lady like this. I mean, in fact, she's got 3 M2 divisions separately sticking out of the top of the aneurysm. It's a real blowout at the MCA bifurcation, and this big one inferiorly. So the green line there is depicting where we want the back edge of the device to land. And in fact, it did sit very nicely. This is about the 3rd case I'd ever done, and it actually landed not through any good management or good luck, but you can see the way it's sitting on the unsubtracted view on the right, preserving all those M2 branches. And on the left, you can see how it's already excluded the dome. So it's early, we'll get some follow-up. If it recurs again, she's 72, so it's not a disaster. If it recurs, you know, she'll probably be all right with that for the rest of her life. And this is our meth guy. Again, we want to protect his dome. What we really want is to get a result like that, a clipping-like result with this guy. And again, it would have been a really hard stent coil and a really hard balloon coil. But in this case, the web actually sat quite nicely. You can see it refashioning that little segment of the vessel there. So, you know, that was a really nice treatment, I think, for him, for a guy who's likely to disappear into the wilderness for a while and who was really not up for a craniotomy. It was hard enough to get him into hospital for this. So to wrap it up, you know, there are a lot of different ways to treat aneurysms with difficult necks. I try and keep it to a minimum and keep it simple. But you do have to tailor the treatment to both the aneurysm and the patient. You know, you've got to take into account whether the aneurysm is ruptured or unruptured, where the aneurysm is, and how easy it is to get to, both endovascularly and open, the age of the patient and their social circumstances. Again, try to avoid using too many devices, and I think that's particularly apt for low volume centers, particularly if you're not doing many aneurysms. It's really important you stay familiar with a few devices and use multi-purpose devices wherever possible, and keep it simple as wherever possible. And I think our colleague from Shanghai yesterday summed it up beautifully. So I put this back in because I think it's really important for everyone in the room, not just low volume centers, but it's really important you do one thing a lot of times rather than one thing a lot of times. No, a lot of things one time rather. Anyway, on that, I'll close up. Usual acknowledgements to my colleagues in Sydney. I'll be seeing them all in a couple of days and back on call. Thank you.
Any questions for Jason? So I have one for you, Jason. How many aneurysms, and please, that's not a sin, we still do that in this country, in Brazil. How many aneurysms get clipped at your center in Sydney every year?
I work across 2 centres, and they're a little bit different. So the centre in the east of Sydney has pretty expert neurovascular surgeons. The centre in the west has one very good neurovascular surgeon, but he's not on call all the time, obviously. So that has an impact on how things are treated. In the east, we treat about 125 aneurysms endovascularly a year, and probably 30 get clipped, 20 to 30 get clipped. In the west, we'll do about the same number endovascularly, but probably only 10, 15 get clipped.
So if you would have had somebody, if this patient would accept a clip, he would be...
Yeah, look, I mean, we tend to lead the discussion because we treat more aneurysms, and we've got more experience. The endovascular guys have more experience than most of our clipping colleagues. It's just the way things are going, and I'm sure that's the same here. But we take the time to have the discussion about every patient, whether it's a narrow-necked basilar tip aneurysm or a broad-necked MCA. We'll sit down and have a chat about it, even if it's for form's sake. It's important we do that. I think we add that to the patient.
Questions, comments? Thank you, Jason.
No worries.
We have a little change on the program. We're gonna do. Naji has to leave at 2:30, so we're gonna go back to back here with his talks. He's gonna give us a brief version of their experience with high-grade AVM, and they're doing something that is very interesting for us as neurosurgeons. They're doing high, and he'll show you here. I'm not gonna steal the thunder. He's gonna show his experience, and then we're gonna discuss the first talk, and then we're gonna go for the spinal AVM part, and then we'll be done with AVM session.
Thank you. Good afternoon. We started to treat AVM and do injection by using run. And then immediately after learning how to reduce our concentration from Jack More, and we're having longer injection time, and we started to use the roadmap. And we changed our strategy. We were treating just fistula at the beginning, and started to treat more plexiform nidus. But treatment options is the meaningful from team to team, and indications also really inhomogeneous in terms of how to select, when to select, how to combine. And then Onyx appeared, and then after having Onyx, because it is actually a non-sticky material, we started to inject more than expected. And even from one single microcatheter, we could able to treat such huge nidus from one single catheter. And then we are getting more and more complication. Whenever the AVM is getting bigger, the results are getting worse. Such images, for example, around the nidus, immediately after occlusion, we started to see such stagnation. At the beginning, we don't realize are those veins or arteries. And then we change our protocol to reduce our complication. We let the patient sleep for a while, and we started doing control run in the next day, and realizing that that perinidal and large vessels are disappearing. That's why this is the second day angiogram. We started to do that protocol. Wake up time is longer. We don't take the introducer sheet. And I'm not surgeon, actually. I went to radiology just because of the intervention. And then our neurosurgical team, we are working as really as a team, waiting in that period. This is the 8 month of angiogram of this particular case. Let's check the meta-analysis of the liquids on AVM. This is from 18 to 2012, 13. Look at the complete obliteration rate. This is including all high grade and low grade. For NBCA, it is something 13. For Onyx, it is around 30. And the poor outcome is something around 5 or 7. Is this a success? With the EMBO only, that type of hemorrhagic complications in the literatures. And then that, of course, when when you have a partial treated AVM and when you have a high grade AVM, the numbers are increasing up. It is so obvious that we're not good at on AVM treatment by using single EMBO therapy. And multi-stage embolization. We created a multi-stage embolization strategy to decrease the so-called famous perfusion breakthrough syndrome. But multiple season increase the risk of complication and the cost, and also the anxiety we created in the patient and the family. And we're doing every step with the same mentality. Actually, subsequent surgical resection has now been clearly delineated. And then another thing is very important: partial treatment of AVM does not eliminate the rear rupture, does not eliminate does not lower our complication rate. When I check that the EMBO and surgical group, there is a big inhomogeneity, everyone doing his own style. And even in the same group, there are inhomogeneities. And nowadays, there is a general approach. In grade 1 and grade 2, the AVM, especially grade 1 and 2 AVM, microsurgical resection is the best. But we are also good in grade 1 and grade 2. And for grade 4 and grade 5, we decided let's wait. So-called, we call that conservative management. And grade 3 is a very heterogeneous group, and you can see everything. Then we started to do the same-day surgery, starting with the EMBO and then finishing the day with surgery. What we get from this? We get a complete AVM obliteration, shortest possible time frame, and we have some reductions. What are those? Radiation exposure, procedural-related morbid mortality, interprocedural-related rate, and we are also eliminating the patient and the family anxiety. For example, this case is the medium-sized AVM fed by posterior circulation and the MCA anterior circulation, the multiple draining vein. We did our best by using overlaying technology, multiple catheter, and then we really did our best. When you check that the posterior circulation, it looks okay, but there is still some vein is filling. That means there is no real treatment there. And when you check the anterior circulation, there is a remnant there. Even we did our best in our injection, we cannot able to reach that part. And what is the sense to leave this alone and get another session? And that's why, to prevent every complication, we sent the patient to the surgical room and that they took it out. And at the end of the day, it is over. And you can say to the patient that your AVM is done. We don't need to do another session for it. This is after surgery from the anterior circulation. But you cannot do this in the deep located AVM, including brainstem, deep cerebellar nuclear region, and thalamic AVM. You cannot, of course, cannot do this technique for that. Another case, ruptured, again, the same best possible technique, and multiple catheter injections, and this is after embolization. You don't need to send the patient. Everything is ready, the setup is ready for surgery, but after having a perfect, proper feeling of the nidus, you don't need to send the patient, it is done. It's and only EMBO cure. Another case, temporal, again fed by posterior and anterior circulation. This is the posterior circulation. You don't need to go there because this is, collateral flow. This is anterior circulation. And again, that you did your best, starting from a little bit away from the main vein and ending up to feel the nidus. And after having this total occlusion, again, you started to see that type of vessels around the nidus. Not early venous feeling, but there are vessels there. This is the problem of this technique. Even we have a good results, we have still problems to have a perfect decision in that period. Should we leave this nidus there or should we take it out? In this case, we decided to leave this case because there is no early venous feeling. We can control the blood flow. And this is immediately after. And this is the 1 day later. You can see that reduction of the perineidal vessels again. Another case, very similar. And I did my best. Again, I occlude to nidus. No visibility in the venous falls. Look at that, it's clear. Everything is perfect. And this is the posterior circulation. Patient wake up fine, we are happy, no stagnant vessels. And then this is the immediately post-embo cone-beam CT, showing subarachnoid space hemorrhage. When you look at the literatures, it's up to 10% because of the retraction of the vessels, especially for tortuous arterial feeders. You can see such things. And then we decided to wait a little bit. It was a fault. It was my fault, and it was my decision, and that bleeding is enlarged. And we rushed to the operating theater. And because I know that I retract the arterial feeders, it is transarterial therapy. And I asked the surgeon that please get rid of that upper portion of the nidus, that the main vein is the lower part of the temporal lobe, and they didn't touch that portion, and they didn't see any bleeding, active bleeding. And the same day, same night, he ruptured again. At the end, the Sylvian hematoma is increasing up, and the patient now wake up well and has a morbidity, of course. This is the only case in this group we had morbidity just because of my fault. This is the only case after having that suspicious and obvious rupture, we didn't take the nidus out. It was in front of us, we left it. It was the fault. By doing so, you really reach the fantastic images like this case. And unruptured, but the very huge AVM, grade 5, symptoms coming from the venous side with an aneurysm. And you can do whatever you want, a double catheter technique, pressure technique, or what in transvenous, and you can able to reach that occlusion. It is for us a piece of cake to occlude that part, but we left this part just because to prevent that early venous thrombosis. And then sent the patient to the open surgery, and they took it out. In the same day, you were treating the grade 5 AVM. And he was in the coma, and then in a month later, he started to sing, he started to eat by himself. And of course, it's morbid. Overall, this was the last year's presentation, and then the numbers is a little bit higher right now. But when you look the obliteration rate, we achieve almost 100%, except one patient. And then permanent morbid mortality really comparable with the high-grade AVM series, even in the surgical or endovascular one. And we are selecting the patients very carefully. Our AVM indications is mainly in the rupture one and intractable seizure. Headache is just on the 3 with the morphological weak points. With that approach, we are eliminating AVM in 1 day, 1 attempt, no staging at all, talking about high-grade AVM. And then we are actually curing post-embo hemorrhage. And, but perineidal vascular resection also let us eliminate that so-called non-visible vessels, which is not visible in the angiography, but the surgeons always saying that there are vessels there and that they create hemorrhage. We are also eliminating that once. One thing, we are a little bit more aggressive, that we are trying to do our best, and then our embo strategy is changing because we are not thinking the staging. We are attacking the nidus accordingly to the surgical technique. And then you are started to think to embolize and navigate from the feeders in a different way. But it is a long day for both teams, and we are also sharing the responsibility with that 2 teams. Of course, the patient hasn't got a long anesthesia. In conclusion, the AVM is still a very big problem. in our society, in neuroscience. But this type of technique may give us another chance of a treatment of that the dreadful pathology. Thank you for your attention.
Questions, comments for Naji?
Excellent, Naji. Our experience with transvenous embolization has been that when we do cortical, it's fairly approachable after we devascularize transarterially. But when we go to the brainstem, what we have found out is that the complexity of CP angle, when we are down in brainstem pontine, cerebropontine area, and we do their transvenous, that we see veins that we don't see angiographically. And I wanted to ask you your experience. How do you solve the problem if you want to address transvenously in infratentorial locations? And I really am completely mesmerized about the paths when you go into the posterior circulation to the venous approach.
By cone beam CT. By cone beam CT angiography, either from the proximal vessel injection or from microcatheter injection. You will see from my spinal talk. It is very helpful. The only problem of cone beam CT angiography, it is not dynamic, it is static. But you can compare the static images with the dynamic one, and you can reach understanding that type of vessels. Because otherwise, I agree with you, your guide wire is going somewhere, and it is really, you know, fearful. You are feeling that you ruptured the vessel, but actually not. I first learned how to deal with the brain AVM transvenously from Dr. Hudak in Hungary a long time ago, and now it is popularizing right now. But still, I have a big question in my mind to do the transvenous for cortical high-grade AVM, because you never know that you can reach every part of the nidus transvenously. But for the small diencephalic brainstem AVM, yes, we are using transvenous.
Naji, for those of us that do part 1 and part B, we embolize and then we have still to go to the OR. That becomes like a short 26-hour, 36-hour day. What is your suggestion? So because you guys work with 2 teams, right?
Yeah.
The embolizers and the cutters.
You know, my good friend Dimitrius, after seeing my presentations some years ago, he went to Chicago back and then the huge AVM by himself, starting the day early by embolization, and ended up with the open surgery. And then he mailed me and SMS me that it is not a good technique, you know.
3 days later, he made
yeah, that is very critical. Now you guys, that you are a surgeon, you can do both. The one good thing from that technique, as a surgeon, if you know the vessel anatomy in front of you by dealing with the embolization, at least one of the embo team members should be in the operating theater. Not the primary one, but secondary one, because he already worked on that anatomy, especially in the huge AVM. You are losing. You are losing yourself. And then with the open surgical mentality is far better than embo technique.
How crazy you think would be? Like in old days, Spatzler and others would cut and shove a muscle on the AVM, so direct embolization. I'm on the pedicle. I'm gonna take this patient to the OR anyway. So instead of doing all this malabarism of going through the groin, sometimes not get where I need to go, I can get into the arterial feeder, feed the microcatheter right there and tie that pedicle. So that is the ultimate pressure cooker technique. I'm tying off that artery around the microcatheter and then embolize the heck out of that AVM and then resect. I'm talking about this type of disease that you're showing here, because this patient is going to the OR anyway. So what do you, because the first time I saw you talking this, that's one idea that came to my mind. Again, I'm gonna open the head anyway. Can I help my endovascular skills by putting my catheter into the nidus itself and then tying my pedicle Because again, this is beginning of embolization. What
Let
do you
me-
guys think about that?
Yeah, let me tell you my first case to decide this. It was 2006. I was doing an hospital AVM, and the one catheter stick, I couldn't take it off, and the second catheter is about to stick, and at the end, I couldn't occlude hold the nidus, and my second catheter also stick. I couldn't take it out, and I was trying to take it out, and I had a rupture, a huge hematoma. And we sent the patient to the surgery without the manipulating the catheters. And then I went there also. They took it out because that hematoma let them go to the nidus easily. And they cut my microcatheter tip over there. And they took the residual microcatheters from the groin immediately. And we realized that it is very safe. And the patient woke up nicely because it was in an hour. You know, all the transportation and opening the heart. This is something, the safety point. I'm a little bit aggressive endovascular therapist, but for AVM, not really. The open surgery, we need open surgery. We really need open surgery. We really need the combination.
Thank you. Any more questions for Naji? If not, we move to the next session, spinal cord AVM. So we're going to have 2 heavy hitters with over a century of combined experience on the spinal cord AVM, almost a century and a half now. Spinal cord AVM. Tips and tricks from Naji first, and then to follow with AJ.
Okay. Let me start with the simplified anatomy. That is a fantastic drawing from Lagunia's group. As you do know that the metameric vessels is getting together and forming longitudinal fusions that creates vertebral artery, anterior spinal artery, and the lateral and medial sacral artery is a proper way. And some of them regress, and some of them left. And what happened at the end? And we have some radiculomedullary arteries, and we have some the meningeal arteries. And one of the most important point in this issue is, well, is the anterior spinal artery. That is crucial because its territory is fantastically large in that tiny structure. And that radiculomedullary arteries goes to the cord in a proper way. You will see it. They have different diameter, and the continuation of the filum terminale and anastomosis with the posterior ones in the conal part, and also anastomosis with the posterior spinal artery with the coronary artery. This is a case actually showing nicely that posterior medullary arteries in both sides. That arteries create rather a network after a while. Anterior spinal artery, more straightforward artery like this. And this is posterior lateral spinal artery. This is right side, this is left side. You can see the anterior spinal artery is more straightforward. And this is very rare to get the anterior and posterior medullary artery from the same root. And then we came to the sulcocommissural artery. That artery is very crucial for treatment, especially for AVF. You will see that is very crucial to understand where they are, where is your microcatheter. And this is the main intrinsic cord supplying system, like this. Especially in the spinal one, by using selective the cone beam CT angiography. Those are Vaso CT. I'm using Philips, and you can able to see that vessels. And this is the venous part. You can see that arterial part. This you can see that sulcocommissural artery centrifugally feeding the cord. the same is for the vein of the cord. How we developed this technique, we were working on that intracranial vessels analysis. Especially we realized that with the proper technique, you can able to see all the pontine brainstem perforators and also the anterior spinal artery. And we adapt this technique to the spine. The only thing is you need to change everything. You need to have a general anesthesia. During injection, you need to stop breathing, and you need to prepare a proper position of the hands. Because of the WASO CT or cone beam CT, you need to turn around the patient. Those things are very basic, but very important to get a proper images like this. This is the radiculomedullary, anterior radiculomedullary artery reaching the anterior spinal artery. These two are the posterior lateral spinal artery. All these radiculomedullary branches, right or left side. And of course, this is not dynamic, and you need to compare those images with the regular the angiographic images like this. And this is again, anterior spinal artery. This is conal basket. And this is vasocorona. It is clearly, you can clearly see that posterior spinal arteries is having anastomosis with the anterior spinal system. If you see those connections, you can have a better treatment options for especially glomus tip or intramedullary tip AVM, and also the perimedullary AVF. Spinal veins follows the artery, and also you can see that spinal veins while giving the time to the system, cone beam CT angiography, to get the data little bit late. And you see the networks is from the posterior one, and then reaching that the anterior spinal vein, and at the end the epidural and radicular vein, and the extra spinal the vessels. You see how nicely collecting together. For spinal vascular malformation, you need to look at the extra spinal group. For this, for example, this is the medial tentorial AVF, but draining into the spinal vein and creating that the venous stagnation. And then this is the glue after embolization. Or you need to look at the sacral group. This is the paraspinal AVM. It is really impossible to reach there by transarterial route. And by using transvenous route, you can come to the point here and just glue it. That's easy. The difficult part of the treatment is reaching that point. And this is post-embo. Typical dural type 1 fistula. This is again from the sacral one, internal iliac one. You can able to reach there. The important thing technically, you need to take the proximal portion of the vein. If you don't take the proximal portion of the vein, the collaterals are very rich and then it will recur. That is simple rule for endovascular or open surgical technique. We are using modified Takai system. There are a lot of classification. Also, my friend Jivan also add something on it. They said the intradural venous drainage, as we are calling that, intradural medullary vein or non-medullary vein, because intradurally there are a lot of vein. That is changing your strategy and emergency. And this is a good example of the type 1 dural AVF. You see the drainage pattern, and then the the meningeal branch. You see how nicely visible all the arterial venous structures. And you can see that, same case, you can see that this is the channel, this is the fistula point, and then this is the fistula point, sorry. And you can understand why these veins are not following the same sulcus. Actually, you really understand that that veins has a bifurcation here, and that's why the drainage pattern is in the anterior and the posterior venous system. And you can see that the fistulas point easily like a surgeon. And it is in your hand. You can manipulate your the mouse and then cut the raw data according to your wish, your vision. Time to time, the anterior medullary arteries arising from the feeding arteries of the radiculomeningeal branch. In those time, it is better to send the surgery if you don't deal with too much with the liquids. The surgery is the best. But if you have a good stagnant flow with your microcatheter and you really have hands to inject that one, you can do it. It is an old case, 2001. And by having a good material, again, the type 1 the fistula, you can do such shape with your microcatheter to reach the feeding artery. This is the availability of the technology in our hands. It is really good. This was marathon, by the way. And the upper one is the contrast. The lower one is the glue. I prefer glue. My first choice is glue because really good, controllable, and visible. Mostly, I'm using 30 or 50% in that group. And as you see, when you have a backflow around the microcatheter, when I reach that region, you need to stop. Because of what? After embo, okay, the fistula is eradicated. Look at how easily contrast material go up and down to the upper and lower intercostal arteries, and you can see another radiculomedullary artery arising from the upper one. You can easily occlude that. That's why you should have a better visualization. During injection, you should stop your breathing. That change helps us a lot. This is the same case, 2-month follow-up. Come to the intramedullary ones. These are very difficult. We are actually selecting those cases if they have a rupture. And please pay attention that continuation of the medullary artery after embolization. Your microcatheter tip should be in the coronary artery. You should be clear that you are in the coronary artery. If you are in the anterior medullary artery and injecting that, eliminating that nidus, you create a fantastic paraplegia immediately. There is no the place for backflow. You should have a full flow control. And another one, and it is such obvious that in these nidus, it is impossible to have a total cure. And this is not our aims. What is our strategy in this group? If the patient already ruptured and that rupture point is visible, and we are working on it very carefully, and selecting the feeding arteries, it is this here. And putting the catheter, do as much as possible, not try to occlude to total. In this case, we really did good. And at this part, we don't force ourselves to occlude. And time to time, we are putting 2 microcatheter, and this is AJ, what I'm saying, for the venous and arterial details. Look at that, 1 catheter on the right side, the 1 catheter on the left side, just to understand what is the anatomy. This is the same for the brainstem AVM. And you can see that vessel going into the nidus. This is the nidus. This is not fistula. This is the nidus. Time to time, it is mixing. Which one is nidus? Which one is fistula? And then our microcatheter is there. And sorry, our microcatheter is there. And then we have a partial embolization, not forcing our chance and the patient chance too much to have a total occlusion in that group. Another one, that some veins are enlarged. This is the fistula. It is actually simple looking fistula, but it is complex. And how you can treat this one? You can treat this one by coil. Why by coil? When you look at in a details, this is anterior spinal artery and continuation with this one. To understand this one is crucial. And you need to stop here. And by liquid, it is hell difficult to stop here. Now we have a chance. We have miniceptor is coming, and a dual lumen catheter will help us. But even with the liquid, to stop in a very, the exact point is not easy. And by coil, you can easily do it by protecting the anterior cerebral artery. And the crucial thing is to really understand where is coronary artery, where is main artery. And this is immediately after. And for the fistula case, again, and instead of using the liquid time to time. I'm using coil. This is the case. The multifeeder is feeding the fistula, the type 4C. And I choose, of course, the posterior medullary artery, this one, to go there, not the anterior one. And I put the coil. Look at the coil. It's filling in the sac. And I call it, have a total occlusion. And I try to get my microcatheter, another microcatheter, to go to another vessel. I realized that coils are changed the position, and coil now in the sac. See, it is on the calyx, and then it is in the fistula right now, in the vein now. So started again, put another group of the coil, and now you are there. You can inject little glue, onyx, in the coil, in that segment. And of course, you cannot do such manipulation in the anterior spinal artery. And then go to another branch, and then this is also glue and reducing the flow. This is post-embo. And by having this, first thing first, again, look at the coronary artery, how nicely, this is anterior spinal artery, and this is coronary artery. And again, the multiple feeder. And the catheters inside the nidus, this is in the vein. And look at the cast. You don't need to extend your injection towards the proximal the vessels. And please take care of that coronary arteries. You can inject your liquid into the coronary arteries, easily reach the anterior spinal artery. It is in a second. And this is immediately after, see the protection of the anterior spinal artery and the preservation of the posterior spinal artery. Again, the location of the material, yeah, immediately after embo. This is again, the follow-up, a year, hold the system, turn back to normal size. And this old case, the single hole fistula, not easy to treat. It is totally anterior spinal artery. And then glue, high concentration in the coronary artery without having backflow. You can have such results. Now she had a baby. She called me last month, and she had a baby. And you can see the resolution, regression of the venous push by time. And but for AV fistula, perimedullary AV fistula, and the dural AV fistula are targets, are target of embolization. Another one, ruptured. That is interesting. I want to ask all of you a question. Now that we look at the arrow, what is this? This is lateral. This is, who are saying that it is anterior spinal vein? Who is in favor to anterior spinal vein? Or artery? Who says that is artery? Who say, I don't care? Okay, this is very interesting case. It is actually ruptured in the lower pathology. And this looks like a vein, no? This the tortuous, this is a vein. But this is glue cast. And let's do what's going on. Actually, this is anterior spinal artery. Why that anterior spinal artery is so enlarged? Because the patient has another fistula in the cervical region. And so that, don't look at the morphology itself. To follow the vessels till the end. And then otherwise, you will have a big problem. By definition, that vessel as a vein during injection, you will have a big problem. And this is the 1 month follow-up. The lower portion is gone, and still he had a fistula, but no venous edema, and we don't want to touch that fistula, leave it alone and follow the patient. So, and this is the lower part. Again, this is the almost a year follow-up. See the anterior spinal artery arising from the vertebral V4 segment going down. In the paraspinal AVM, things are really easy. By doing that, the Vaso CT or Cone-beam CT, you can easily delineate the nidus or fistula part. All the rest is vein. And going there with your microcatheter, this is it. Very simple, a piece of cake. Look, don't look at that, the crowd, and just embolize it, is over. And that paraspinal or extraspinal malformation is really easy to treat. This is the follow-up. The only thing, don't forget that this is static images. That's why you need to take care of the vein and artery at the same time. There are some tips and tricks. That all the tips and tricks is hidden in the anatomy. When you read the anatomy and the size of the vessels, the direction of the vessels, all is written there. It's well written there. Only thing, we didn't see those things before altogether. We should educate ourselves to adapt our previous knowledge to a new technology. And careful analysis of the vascular anatomy and understanding what type of pathology you are confronting for, and then looking selectively and to the anterior spinal artery is crucial. And of course, the embolic material selection is also another things you need to think. Thank you for your attention.
Thank you, Naj. AJ, you're going to present from your laptop or you? Okay. So while AJ get ready, Naj, these beautiful cone beam CT images, can you tell us a little bit about your protocol?
Sure.
Which button do I press on my Philips machine, and what is
red
your
one?
The gray one, the red one? No, that's self-destruction.
You know, Ricardo always teasing me on that because he also has a Philips system. How you are getting such beautiful images? I said the humidity of the Istanbul is letting me that bright images. So our protocol is simple, Ricardo. According to the catheter position, according to the the flow in front of you. And then you may do a small amount. Now I had a protocol, I already reduced the contrast amount. I'm not diluting it. I'm about to publish it. We're just giving us pure contrast material. Of course, you're turning 20 seconds around the patient. And then giving, depending on the flow, 1 or 4 second delay. And then that's it. The rate, again, depending on the vessels.
What's your average?
You cannot say average on the tiny radiculomedullary arteries and the vertebral artery. And but it is altogether total volume should fulfill that 20 seconds.
So this is VasoCT. What is our
This is
protocol?
VasoCT. Philips called the VasoCT. Siemens calls the DynaCT.
What is our injection rate for stent protocol?
I send you, for example, 10% dilation.
Uh-huh.
I mean, 10% contrast, 90% dilation, and the 4 by the 20 or 80. Sorry.
Because again, whenever we try, we never get this picture. So there's something wrong with the operator.
Humidity of Istanbul.
I blame the tax, but that's okay. Any more questions for Naj? Thank you.
Thank you for your attention. Thank
you. Tips and tricks from Boston.
I think I have it on the laptop here. No, over there. First of all, thanks again, Ricardo, for the kind invitation. I think that Dr. Kosher basically covered everything. So I don't need to talk, but I want to go through some tricks or tips I can give you if you do spine. First of all, I would stay away from spine vascular work if you don't do a lot of them. And it's even for surgery, open surgery, really challenging. I remember the time with Spetzler, real spinal cord AV malformation to treat them is really requires a huge amount of skill because there's a lot at risk. Imagine you are working on the brain where you have the MCA with its perforators. Now you fold the whole thing and downsize it to a few millimeters in cross section. So that's how it works in the brain, and I think that it's important to keep that in mind. I will show you, unfortunately, I don't have the laptop, so I can't, I have to focus on one or the other screen with my pointer here. So I think there are a few aspects. I have really a longer talk, but I've put it together what I think are the essence. I think, first of all, it's important to understand the anatomy. And you heard from Dr. Kosher to separate veins from arteries. It sounds simple in the brain, but in the spinal cord, it's not easy. I will show you a case where it's really difficult to separate that, especially when the shunt is tremendously high. The other thing is, what is important is to use the imaging, intraoperative imaging you see from the discussions, and cone beam CT and MRI will help you a lot to understand that. Then embolic materials, we have at least 3-4 different embolic materials. I don't use onyx for spine, and I can tell you why in a slide shortly. So there are a lot of basic research happening in the spinal cord AVM, and this is for those who are interested in looking into that, and it's interested that there is some work done in the genetic area that triggers basically and activates endothelial cells to develop AVM. And similar things happen in the spinal cord as well. And it's interesting because that makes us understand why AVMs, maybe unlike aneurysms, are congenital in their nature. Regarding what is happening in the imaging world, you heard cone beam CT. These are the most recent detectors, and Philips, we work with Philips, but Siemens is going the same path. And I think that working on the equipment with the highest capability of doing cone beam or resolution is important. So what do we use in spine? Like in the brain, I have here an example of the brain. We have the 3D rotational angiography. Why do we use that in spine? If there's a significant overlap, to get a projection, work projection. Helps a lot of dye injections to minimize, because you will otherwise putz around. The other thing is, do we have something similar as the expert CT or cone beam CT for spinal cord itself? Is it useful? No. It's not useful currently because you don't have the spatial resolution. However, the variation of the cone beam CT, which is called the vaso CT, because of its high spatial resolution and contrast object resolution, gives you a very good information whether the lesion is a shunt in the epidural space or in the dural space or truly intradural or cord space. Sometimes it's not easy. I've often seen after MRI, they're finding, oh, this is a dural AV fistula, and it turns out to be an epidural fistula or a PL fistula. It's not that easy. And I think that's important. And with the cone beam CT, you can solve that. Here is a picture similar to what Naji showed you here on the right side of a true AVM of the surface of the spinal cord. So you see that that's something helpful, similar to what we see in the brain. So utilize that. Now, my choice of embolic agents for spinal cord AVMs and shunts whether it's a pediatric population, we see a fair amount of metameric disease in the pediatric population, is glue. The reason being is penetration. Glue penetrates generally up to 50 microns, and this is how we use it. And onyx has a penetration into the micron areas, 10 to 5 microns. So you get significant more damage to the cord if you accidentally end up having spillage and you don't see that. Simple as that. You won't see angiographically during injection onyx. It's impossible. The reason being is just the depth of penetration. And I was involved in a case on in a deposition as an expert witness where somebody had done a dural AV fistula with onyx and had filled the entire spinal cord below T10, including anterior and posterior spinal artery, and he didn't see it. And I understand where that comes from, just because the material is invisible at that small structures. So what is the goal of an spinal cord AVM? Similar to the brain AVM, what is the goal is basically you want to occlude the nidus. Now, what is the nidus? Nidus is nothing else, histology-wise, than the connection between artery and a vein at a small minuscule level. That's what a nidus is. It looks angiographically like a big black hole, but if you do super selective injection, you will recognize there are tiny connections, precapillary connections between artery and a vein. Now, when we look at that, when we look at a structure, what are the parameters to make the decision how to approach this? These are details, and I thought that Ricardo wanted to hear from us the technology, techniques. We look at the length, how far we are from the nidus. We look at the nidal architecture. How is it structured? Is it high flow fistulous type? Is it low flow? And what are the embolization goals? Is your surgeon or the person who does the surgery going to operate it, or are you thinking of using gamma knife or cyber knife to remove the remaining part? So that's important. Or are you going for cure? I will show you a cord AVM or metameric where we go for cure because surgery is very difficult. And then infrequently, and I remember that Eric sent me a picture of an anterior spinal aneurysm, was not associated with AVM, that spontaneously resolved. Is it goal to close the aneurysm of an anterior spinal artery? Those things are important. That's on the architectural side of the disease. Then on the other end, which is the technicality we use, is how do we control a nidal cast? And there are different ways to control it. We change the pH of the solution. So if you want a low viscous material with a delayed hardening, then we add certain things to make it more acidic that delays the polymerization and yet gives you a very deep penetration. And then you can use PEEP. If you work with a good anesthesiologist, you have high flow shunts, you can work with a PEEP, and that works in the spinal system very well. So these are the key components, starting from the AVM architecture, the flow dynamics, and your technical aspects of this. If somebody is interested in looking more, there's a Rothman's recent spine book. We were asked to write a chapter about this, so we have detailed the whole thing there. So what are the key components when you use a high resolution angiography? Like I said, imaging is very important, but also the materials you use. So let me briefly go to the first material, NBCA. We know NBCA is an inflammation, creates an inflammation. So even if you think you have not completely closed an AVM, you will see delayed occlusion due to inflammation. That can happen. It's helpful, can be also negative if you are in a very deep structures of the brain or spinal cord. The other thing is, and that what I want you to take from the slide is the penetration. The penetration, when we look in our own studies here, reaches approximately 50 microns, like I said. So you are dealing on the safe side, even if you use different dilutions. What about Onyx? This is from Natarajan paper in Journal Neurosurgery. Penetration 5 micron. That's why you heard also from Dr. Kojar, he prefers using glue for the same reason. It's visible and it doesn't have the same penetration. Here's some studies where we have changed the concentration of the glue here as well as the acidity, what it does to the penetration. Here on the left side, you see a glacial acidic acid, no addition, same ratio between glue and lipidol, which is a product to visualize it, but also give it the shielding effect from ions for prevention of the polymerization. And on the right side, you have the same material, but shifted in its pH value. So you see the penetration is different, the distribution is different. And if you do spatial staining, the behavior in the nidus is different. So those things are tricks, we use it. I will walk you now through a few examples and then we can have a discussion. This is a true spinal cord AVM. Some of you know that as type 2 or yeah, it's the true. Now, dependent like in brain itself, you can have a supply from the anterior spinal artery through the sulcocommissural artery, you heard it before, or you can have it through the PL or superficial anastomosis through posterior spinal artery, like in this case, as well as through the perforators from both posterior spinal arteries. Why is that so important? If you have a situation where there is a posterior and anterior, so posterior and anterior supply to the AVM, you have to start thinking, what is the goal of your embolization? Can you cure the AVM, or do you end up closing from the anterior circulation, so the anterior spinal artery access, and then leave the surgeon in the posterior? It's not always an easy decision. So that is something really that needs to be discussed upfront. Another case, a young man, 18-year-old person, came with a subarachnoid hemorrhage, angiography negative, completely intact. We do an MRA, and you see already in the craniocervical cord flow void, and you wonder how can this gentleman be asymptomatic, correct? And I have seen surgeries in this area from anterior approach, not an easy surgery. So what do you do? What did we decide to do? We started with the angiography. So you do the angiography and you find this, I think it's the next one. Yeah. You do the angiography and you find this spinal cord AVM. This is the frontal view, left vertebral artery. So much steel that you really don't see even the basilar trunk as well. And this is the same thing laterally. So when we go with the microcatheter in the anterior spinal artery and inject it, you will see these glomerula, those compartments of the AVM. Now, obviously, you cannot, like Naji properly address, you cannot embolize this AVM through the anterior spinal artery. So what is the goal? You have to take your microcatheters into the sulcocommunicable artery. This becomes really a very tedious work. We have now catheters and wires to do that. And as you see here, this is an injection from an sulcocommunicable artery and its own draining vein. Another compartment. It took us 6 sessions in this young man to close the AVM. You see then at the end of the embolization, what the goal is to push the glue inside the major draining posterior median vein here, what you see here. So you start compartmental approach, slowly devascularize that, and you can still back off and say, okay, we reached our goal, the surgeons or radiosurgery can kick in. In this case, we decided to go for a cure. This is the final result. Down your frontal, you see the anterior spinal artery on both sides with complete devascularitis. You can do that, but it takes, like I said, again, a lot of work, a lot of patience. It's not a one shot and that's done. Now, another situation which is somehow a similar disease, it's called type 3 or the metameric type, which is a composite of all 3 layers. So you have ectoderm, meso, and endoderm. We are more interested in the cord part. So in this case, so you have, of course, involvement of the vertebral body, but we are interested in the cord itself. So this is how it looks. That was a gentleman who thought that he had a neck injury because the dog pulled him on the beach and he fell on the back and had a pain. And then turns out that he bled from this. This is a typical metameric 3-layer disease. Looks very dramatic, and it is dramatic to treat it. So what we decided to do is we decided to go to the anterior spinal artery and then through the sulcocommunicable artery to take down the cord itself. Again, a similar approach what you saw in the before. Again, the pontomesencephalic or anterior median vein that drains up into the brain, that is your final goal. You have to get the glue finally into this piece if you want to cure that. So the next picture shows you after several sessions, obliteration with preservation of the anterior spinal artery, there is some piece here in the soft tissue left, which is not important for the cure of this disease itself. But the goal was, again, the spinal cord component. This is how it looks on CT scans close to the dens itself. Now, there are other shunts that are easier treatable, and you saw that from the previous speaker, that drain into the spinal cord. And I will show you this one. Very interesting case, a young man, of course, when we get older, everybody is younger. So this guy is 55 years old. Yeah, it's dramatic. I call now 70 years young. Then you realize. So you see this young fellow here, MR scan, and when you look at the CT scans, and that's important. The CT scan shows you a ventricular hemorrhage. And then when you look closer on the MR, you see on the right side in the CP angle here, some flow void right there. So we did the angiography and you will see, well, the ruptured aneurysm, superior cerebral aneurysm, that's the culprit. In fact, it's not the culprit. When you look closer, inject the other vessels, you will see what the culprit is, the tentorial shunting or tentorial AVM that drains down into the spinal cord. So we did an analysis over 300 dural AV fistula at our place and discerned 104 cases where there were aneurysms associated with dural fistula and found out the reason for the bleeding most of the time are the aneurysms and not the dural fistula. In this case, it's exactly the other way around because it's a fourth ventricle bleed, so it's a venous congestion that led to bleed. So how do you treat this case? You see the lateral dural, the superior cerebellar artery, there's an aneurysm, and then you have the dural branch. So what we decided to do is pass through the aneurysm and place the microcatheter into the dural branch. And that's how it looks. And you go selective, and now you are at the edge of the tentorium, injecting that, and this is how it looks. It's a fine network of connection between artery and a vein. So the goal now is obviously to get this structure as well as the draining vein, the proximal part, to disconnect the disease. And that's what we did. We injected the glue. You can see it nice. Like I said, glue you can see. Onyx, it will be very difficult to see in this location. So finally, we got the cast here with the vein. So we disconnected the artery from the vein. This is how it looks. And this is the final result. And you can then address your aneurysm, and that's what we did. We pulled back and then went with the other catheter and placed some coils and closed the aneurysm. So another short case of a cerebropontine AV shunting here. This is a patient with a ruptured small PL AVM draining into the superior petrosal system. This is how it looks. Again, same approach. Important that you discern the AV shunts and the connections. Use of glue. And this is how it looks. And this is your CT scan, which nowadays with the newer scanners, you can get it on the fly using your flat panel detector showing you the glue cast within the CP angle. So in summary, it's important to understand the anatomy. It's important to classify the disease. Are you in the epidural space, PL space, cord space? Is it a metameric disease? This is another whole thing that needs to be learned. What's normal vasculature, what is abnormal? It's not so easy in the spine, has to be done. And then the next and last step is get familiarized with the catheters, the microhedra. I can tell you from my experience, this is not something what should be done or needs to be done, you know, on infrequent. You have to really dedicate your interest in doing that. That's how I see that. Therefore, I hate to give this talk, to be honest.
Thank you, AJ. I was teasing David Langer here.
Yes.
On his pulverization of volume. I told him, if you're worried about aneurysm, imagine spinal cord AVM.
Yeah, yes.
I don't think that's something that everybody should be doing.
No, I don't think. I agree with you, Ricardo. This is like, this is esoteric, I think.
Agreed. And any questions for AJ?
Any questions?
Last case that you
yes, please. Yes.
Would you consider going transvenous?
Yes, we have done that. The thing is, the downside of transvenous is if you obliterate it too early, not close enough to the nidus, as you know from your experience, you get other paths, and then you can have a hemorrhage. So it's then safer if you do that, park your catheter in the superior dural, into superior petrosal, embolize as much as you can, reduce the pressure gradient, and then close from the vein. I think that's the safest way then to do it. But thanks for the question. Any other question? David, anything? You want to add anything? What is your experience? I mean,
I think that in general, it's similar. You know, I came from the Berenstein School through Rolf Ortiz, who And I think that, flow-directed catheters are really valuable, Magique catheters. You have to learn how to use glue. The trouble right now in a lot of neurosurgeons, even, good programs, they're really moving away from glue.
Yeah.
Because Onyx has become, it's emotionally easier to inject Onyx because you have time and there's this sort of peaceful and patience sort of thing. But I think glue is essential to treat some of the more complicated lesions. And it's very esoteric, but it's an area of why you have to subspecialize and why, I think going back to Ricardo's point, the stroke piece, it's another reason why there has to be almost super subspecialization in the field so that people like this know how to treat the problem. And it's, we continue. It's kind of like the bypass of interventional.
Yes, it's
kind of
like
thing.
that.
So,
do you consider I agree, Onyx is good, really good for brain AVM. And I think that has changed the whole approach to AVMs of the brain. In spinal cord, I'm still reluctant, and certain pediatric population, I stay away from Onyx.
dural fistulas, Onyx change.
Yes,
fistulas,
dural fistula, you can cure nowadays
Right,
dural fistula with Onyx. Question, if you have a spinal cord AVM where a small area is left, do you go rather to radiation therapy, cyber knife, or gamma knife, or do you consider more surgical option?
It's ruptured. I think you kind of have to try to, get rid of it.
Okay.
If it's unruptured, or a patient presenting with venous hypertension or some other, other symptom, I think then you have more time. Often we would leave it and then bring them back. Maybe other portion of it, but you get access from a different direction or a different feeder. But I think if it depends what the symptom is. But these can be. The first thing is not to hurt the patient. And I just saw a case from a friend of mine from Czech Republic, in a case with the ASA supplied AVM with 2 aneurysms on the ASA that's bled. These are just almost impossible. So that you do what you can, but reserve a neurological deficit at all costs.
Okay, thank you for the kind invitation to Jacksonville. Thanks.
Thank you. Just before the break, before people start to leave slowly after the last session, and have you seen, we're really fortunate here to have a really, really good team. A lot of people who get along, and sometimes when they don't, we find a solution. None of that would be possible with the support of many, many people. Some of them have already left, but we just want to make sure that we thank the team for putting this meeting together. So thank you, everyone. Thank you, Brian. Thank you, Wendy. Thank you, Carol. Thank you, Brittany. Thank you, Abby. Thank you, Demetrius. And thank you, Linda, and everyone else that I'm sure I forget.
Thank you, guys. Dr. Naval, 10-minute break, 15. You're the last thing between us and the beer, man. So 10 minutes and let's come back and wrap it up. 4 more brilliant lectures and then beer time, oceanfront.
He moved on to become the president of the Neurocritical Care Society. He's now the chair of neurology at Henry Ford. And again, like I said, truly an honor and a privilege. Thank you for coming, Stefan.
Okay, let's get the talk up here. All right, great. Well, thanks for staying. Now for something completely different. We're going to be talking about multimodality monitoring of the brain. It's something that I've always been very interested in and very passionate about. And what I'm going to do is explain the rationale, talk about some of the technologies that we're using these days. But I want to start by acknowledging the fact that this isn't really the easiest thing to do. It took us years partnering with neurosurgery to slowly build this system. We had to build our own from scratch, a data acquisition system. And we have to work closely with nursing. A lot of this stuff is very nursing intensive as well. To give you an idea, I've been at Ford now for 2 years, and this month, we're now just installing microdialysis. But the intention was there 2 years ago. So it takes time. You go work with hospital committees, and it's new technology, and everybody has a lot of questions and such. Okay, why do it? So this is a movie that came out when I was 15, and the plot line involved human beings in suspended animation. And in particular, in this movie, they were harvesting the human beings to get their organs for transplantation. But that was science fiction in terms of keeping people alive in a semi-death, half-life state. This is our reality today. And this is a woman in a coma. And if you look closely, you can see what we call the bundle, affectionately, 2 probes in her cranium, bringing inside the skull a total of 5 different sensors into the brain to let us see what's going on, right? Because this lady is completely sedated, her EEG is quite flat, and she's fighting for her life. And so we use these instruments as a gauge so that we have real-time information about what's going on with the physiology of the brain. Because let's face it, in the ICU, we monitor. And we don't think twice about monitoring the heart and pulmonary function and end-tidal CO2 and temperature and fluid balance and pretty much everything you can measure. But how do you monitor the brain? Well, traditionally, it's by neuroexam, right? And of course, we do that all the time. But sometimes patients are comatose. We don't have the high-level brain function that we can follow. So I'm going to take you on a little trip about the way that I see the history of neurocritical care in the United States. It really started with neurosurgery, actually. Yeah, I mean, there were the polio epidemics before, but it really started, they started as neurosurgical ICUs in the 60s and 70s. And the idea was that the neurosurgeons were performing this heroic, incredible surgery, very high stakes, and they were going to be damned if the patient's going to be ignored down at the end of some hallway by someone who didn't know what they were doing. So neurosurgical ICUs were created to cohort the sickest patients and to increase the nurse-to-patient ratio, basically. But it was really a lot of neurologic checking, good bedside assessments, but it would at least allow us to react to clinical events. So if somebody stops localizing, stops following commands, if we see a pupillary abnormality, right, the main paradigm was simply swelling and shifting in the brain, producing depressed level of consciousness, right, cranial nerve changes, pupillary changes, motor posturing, and the like. And that was great because we were on top of the patients, and when those bad things happened, we could react. Hang mannitol, get another scan, maybe take them back to the OR. So it's great, but it's primarily a reactive model, right? That bad stuff that led to the neuro worsening and the deterioration had actually been brewing for quite a while. And the patient's now worse. So yeah, we can act quickly, but it's kind of like trying to put the toothpaste back in the tube, right? It's better if it didn't get squirted out in the first place. And so that led to the second phase of neurocritical care, what I call the era of physiologic neuromonitoring. And so the main instrument that we've had for neuromonitoring, and this is a defining technology, right? This was the first real thing that we had that made us different from the MICU and the SICU, intracranial pressure monitoring. You see in the cartoon here some of the history of how these monitors were created in the 70s and 80s, the old Richmond bolt and epidural monitors. They don't exist anymore. Today we use parenchymal microsensors, and we, of course, can transduce ICP off of ventricular drain, although unless there's a sensor at the tip, we're draining and not monitoring most of the time. So it's really about these parenchymal probes. But this is great, because the idea is the intracranial pressure can go up, and we can see that ICP surge to 30 or 40, and we can give our bolus osmotherapy, hyperventilate, or do what we have to do, right? And try to prevent the neuroworsening event. Try to prevent the pupil that's gonna blow in after about an hour of an ICP of 30 or 40. So this is what plateau waves look like if you haven't seen them. These are the world's worst kind of plateau waves you can have. These ICP surges in this TBI patient are going up to 90 or 100. And you know they're plateau waves because you have this mirror type of in reduction in CPP. That's pathognomonic of what a plateau wave is. This is actually the brain vasodilating because it senses it's not getting enough perfusion. And there's not enough room in the skull, so the vasodilation itself drives up the intracranial pressure, that worsens cerebral perfusion pressure, that makes the vasodilation worse until the brain is stuck on the plateau in a vasodilated state. And this is death by ICP, because as you can see, this poor guy here ends up with a final ICP elevation. It doesn't go down. His CPP is down to like 10 or 20, and around here he becomes brain dead. This was my patient, and I knew somewhere around there his only chance to live was a bifrontal hemicraniectomy, but at those days, it was a long time ago, and the surgeons were not interested in creating vegetables as they saw it, so he died. And that brings us to the third phase, or the more modern phase of neurocritical care today, which is what I conceptualize as the era of neurophysiologic brain support. Right? The idea is to get in there and really image, visualize, and see in real time what's happening physiologically to the comatose human brain. And in addition to giving us signals, like when the needle's in the red zone and it triggers an alarm and we react, what I've come to understand is using these devices, we can create and establish and maintain an optimized physiologic environment for the injured brain. Perfused optimally, fed with glucose optimally, sedated when there's abnormal increases in metabolism and electrical activity like seizures. And the idea, right, salted, whatever it needs to be, the idea is to optimize that physiologic environment and to prevent the ICP wave from ever happening at all. So if you go into neurocritical care, it's super fun, especially if you like toys, gadgets, and gizmos. Man, we got them all. And I'm gonna go through these different types of technologies. We talked about ICP. We have transcranial Doppler, which, but I'm sorry, that's not TCD, but we can measure CBF using thermodilution. We can measure the partial pressure of oxygen in brain tissue. We can measure brain metabolism using microdialysis. And we can go into the cortex of the brain and measure intracortical EEG. I'm going to show you at the end of the talk, which can give us really amazing insights about things that go on in the injured brain that we never knew about. And so with this technology, we go inside the black box of the comatose human brain. And what I liken it to is flying an airplane. During the daytime, you can see where you're going. You see the horizon. You're not going to fly into the mountain. But what about when it's dark? And that's what a coma patient's like. You don't have the high-level brain function to monitor, right? So in a poor grade SAH, it's estimated that 1 out of 4 times there's DCI, delayed cerebral ischemia. It presents as a new infarct on the CAT scan that you never knew was happening because you have no exam to follow, right? So that's the rationale why you want to do multimodality monitoring, for instance, in every poor grade 4 or 5 SAH. Steer by gauges. These instruments are your gauges, and they're going to keep you from flying into the mountain. So we add modalities. And if we image the data using conventional time series data here, it can start to get pretty complicated because we're adding more and more and more lines of information. And then we're like trying to figure out, well, like when that happens and this happens and that squiggle goes up and that squiggle goes down, you know, what's going on? And so we realized a few things. First of all, our ICU rooms have not up until now been optimally designed from an engineering point of view to connect, plug and play all the different monitors, devices, machines, ventilators, cooling devices, et cetera. So there is emerging technology to do that now, and the most commonly used commercially available one is called the Moberg CNS monitor. Some ICUs build their own systems. We just installed a platform called SickBay, which is a virtual data aggregator that lives on hospital servers inside the firewall that can grab and collect and permanently store forever all of our physiologic data. But you need something, because there's a weakness to what I called the dead end box, right? So this paradigm is stupid, right? There's continuously displayed physiologic number like an ICP or brain oxygen, right? And it's there, it's never being recorded, it just floats away into nothing. And at the top of the hour, the nurse goes, 12. And that's it. And when you look at Epic, with the way that we write, when you look at ICU physiology deeply, bad stuff, it never shows up in these once-in-hour recordings in Epic, like never, ever, ever. I could show you examples. I mean, it's crazy. So we need to get more in the habit of looking more at our physiologic data, because we can really learn a lot just from what happened in the last hour overnight. When we moved into a beautiful neuro ICU at Columbia, and they said, we'll give you what you want. I said, okay, I want an MRI in the unit. I said, okay. I was like shocked. CT2, yeah. They said, I want multimodality monitor. I want computer in every room for multimodality monitoring. And to my surprise, they said yes. And you see it here. What the hospital didn't know, though, was at that time, I had no plan. We actually just wanted the hardware, but we had no plan how we were going to collect and aggregate the data. But with my colleague for many years, Michael Schmidt, we figured it out, and we used really wonky stuff that I could never do. But you want to end up with this integrated system. And you've got all the machines and devices, and basically I put them in two categories, right? These here on the right are the physiologic drivers, mostly pumps. Right? I can raise your blood pressure, lower it. I can hyperventilate you. I can sedate you, right? I can lower body temperature, hemodynamic augmentation. And then on the left, these are what I call the measures of physiologic brain health, right? We want a more robust, continuous, high amplitude EEG. We want the right amount of oxygen, the right amount of flow. We don't want to have seizures, this and that. So the idea is to turn the dials on the right to move the needles on the left out of the red zone and into the green zone, right? And using this technology, that's what is possible. The next thing I figured out, though, was that actually with all the squiggles and lines, to really understand what's going on, the easiest way to do it is just look at one-on-one relationships, right? Using scatter plots, basic scatter plots. So this is the Lycox monitor. This is measures the partial pressure of oxygen in the brain parenchyma. It's the same thing you measure on a blood gas, PaO2. In arterial blood, about 90, 100. Normal in brain parenchyma, 40. Okay? And what we know is that it's a focal sensor, but largely what's happening in one part of the brain, it's usually highly correlated with the whole brain, an important principle. The other thing that we know from research is that when you measure PbTO2 in trauma, brain hemorrhage, intracerebral subarachnoid hemorrhage, it's practically been universally shown the lower your brain oxygen is for the longer amount of time, it just so happens the worse you do, the more likely you are to die or be severely disabled. And this has been shown over and over and over. Now, that doesn't necessarily prove that brain tissue hypoxia is driving brain injury and causing the poor outcome, but it sure might make sense. And in fact, this is a testable hypothesis, and that hypothesis is going to be tested in the BOOST trial, BOOST 3. ICP management only or ICP management plus PbTO2 optimization in severe TBI. So a brain oxygen level can be influenced by oxygen delivery. It can be influenced by the ability of oxygen to diffuse outside of the capillaries to the neurons, and it can be affected by oxygen consumption as well. This is the first guy ever put a Lycox monitor in. You'll recognize him. He has a right MCA aneurysm, probably clipped because he needed the cranie to do an evacuation. Bone went back on, and we placed a PbTO2 Lycox monitor in the right frontal lobe and a dual lumen bolt with an ICP bolt, 2006. So this is the slide of what happened that first night. So you see up here, here's the brain oxygen. Starts out not too good, right? We want it to be 40 and definitely above 20. So it's below 20. And then here's cerebral perfusion pressure, right? This is calculated off an arterial line, right? This PbTO2 is a Clark electrode inside the brain. But you look at the curves and you notice something really interesting. They're the same curve, right? They're highly correlated. When the CPP goes up, the brain oxygen goes up. When it's low, the brain oxygen is low. Remarkable. And if you take that data and you make the scatter plot, it looks like this. And I saw that scatter plot. I said, you know what that reminds me of? That reminds you of this, right? Total loss of autoregulation. So in fact, if you connect the machines and go beyond the dead end box, a Lycox monitor can give you, let you image the capacity to autoregulate in the human brain, which had not occurred to me before. And in fact, there's no reason you couldn't stream this image, right, and smooth it out and just have the autoregulatory curve displayed right at the bedside. I mean, why not? And in fact, that's exactly what certain groups are working at doing right now. Microdialysis here shows that this is a flexible little catheter with teeny tiny holes. And the teeny tiny holes only let really small molecules in and out. And you have a pump on one end, it pumps the sterile fluid and it ends up at the end of an hour here in this little receptacle. You pop the receptacle here in this machine. That's the old machine. The new one is this big. It just goes around on a tabletop. And it allows you to measure the essential chemical nutrients in the brain. You can measure glucose, lactate, pyruvate, glycerol, and glutamate, right? Glucose, the only real fuel for the brain with the oxygen. Lactate pyruvate ratio goes up when there's oxidative stress and a shift towards anaerobic metabolism. It's an ischemia monitor, right? Glutamate, excitotoxic neurotransmitter, part of the cascade of ischemic death. And when the cells are breaking apart, glycerol is released as a component of cell membranes. So in terms of validation, one of the earliest experiments that was done by a Swedish neurosurgeon named Carl-Henrik Nordström. He just did a lot of microdialysis. And then he said, okay, if this stuff works, then the lactate pyruvate ratio ought to be higher in these trauma guys when the blood pressure is critically low, like below 50, right? Below 50 millimeters of mercury, the hatch bar is the lactate pyruvate ratio. So proof of concept, right? This stuff seems to work. The next experiment that looked at this was by Paul Vespa, very well-known neurointensivist at UCLA. He had 9 patients and he had a lot of EEG. And he said, okay, if this stuff works, the lactate pyruvate ratio ought to be higher in a 1-hour period when seizures occurred compared to those hours of monitoring in the same guys when there were no seizures. And as you can see here, that's exactly what he found as well. Only took 9 patients, but proof of concept about what this stuff can do. So we slowly over the years went from just a dual lumen bolt, ICP, Lycox, triple lumen bolt, we added the microdialysis. Then we added a second burr hole, dual lumen, and we started to monitor cerebral blood flow and intracortical EEG. We made a few discoveries, and I'm gonna have to go really fast, I apologize for that. First of all, we looked at populations of SAH and ICH. Here's poor grade SAH, and as you'd expect, there's more metabolic crisis, high LPR, low brain glucose, and more brain tissue hypoxia in general when CPP is low. Just like that Carl Henrik Nordstrom slide I just showed you before. And we did the same thing in ICH as well, aiming for sort of perihematomal brain tissue at risk. And what we saw is the same relationship, except for some reason, in these lucent regions, a lot more brain tissue hypoxia than we saw in the poor grades. But again, giving us an idea that, first of all, if you look at this ICH crowd, you know, their optimal CPP might be quite high, right? And they might, you know, trauma, we think 50 to 70. ICH in a coma, maybe it should be 100, which means maybe we got to be careful about over-treating the blood pressure with our cardine drips and the like. So gives us new insights we didn't know, and gives us things to think about and new hypotheses to test. This is an example of one patient showing that failure of autoregulation is dynamic, right? It's really out here and the brain oxygen levels are low. And so each day they're higher, and we're able to keep the blood pressure up at a higher level, more in the upper, flatter part of the curve, right? So just pictures to let you see. And another point is when you do the monitoring correlated to death or poor outcome, it's highly, highly predictive of outcome as well. The big multi-center studies showing that have not been done yet, but the single center studies like this one in our ICH population shows that the brain oxygen levels are going higher and the ICP is going lower, and metabolically the brain is much healthier the whole time in the poor grade SH patients that walk and talk one day. We looked at glucose because glucose is the only fuel for the brain. It's actively transported. And first of all, we found that in coma patients who die, their brain glucose levels progressively grind down lower. They're higher and more stable and trend up in the guys that go on to live. And don't have time to get into the details, but we looked at the ratio of glucose in what I call the brain juice, right, the extracellular fluid of the brain, to serum glucose levels. And we found that the ratios are abnormally low. There's failure of active transport of glucose, and the lower that ratio is, the more metabolic crisis there is, right? And the more death. That's more metabolic crisis and a stepwise relationship with more mortality, right? And from a practical point of view, managing coma patients with microdialysis, it allows us to optimize the way we manage glucose with our insulin drips to make sure that we're getting enough glucose into the brain and not triggering metabolic crisis in the brain. Okay, fever, we found that here's the amount of brain tissue hypoxia, percent of measurements with hypoxic less than 15. In a cohort of patients when they're normothermic, there's more when they're febrile. And then when we tried to treat the fever with the Arctic sun, there was even more brain tissue hypoxia. Why? Shivering. And we came to realize that shivering and seizures both metabolically activate the brain and can lead to critical a short supply of oxygen and glucose. And so that observation really was what led us to do all this work developing what I call the Columbia anti-shivering protocol. But if you do any TTM, you know the drills. Goose bar, skin counterwarming, mag drip, dexmedetomidine. And that all came from efforts that we did at Columbia with another one of my colleagues, Dr. Neeraj Bajadia, who's now in Maryland, because we were interested in TTM at the time, and I'd never seen people shiver like this before. We wanted non-pharmacologic ways to control shivering to minimize the amount of sedation so we can follow exam. And then to end, I'm just going to show you one example of our initial experience with intracortical EEG, the so-called depth electrode. This got a cardiac arrest. We were putting bundles into cardiac arrest using standard clinical consent, and then we put them in observational registries looking at outcome. So he had a respiratory-driven cardiac PEA arrest from an asthma attack, young guy, father of 2 small children. So it starts out not looking good. You see very flat and attenuated background, and then boom, you see this one generalized discharge. Boom, 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 boom. Some generalized discharges. Okay. Boom, 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 boom. You get a run of these. The blue on the bottom is what's in the brain, being right, what's coming from the depth electrode. The other stuff up top, that's standard surface EEG. And what you see is he's having a raging seizure in his brain with pseudo-normalization of the cortical EEG. And the seizure goes on and on and on until then the brain's depleted again. How many times is this happening in our coma patients? In our first 15 patients, we found that 10 out of 15 patients were having seizure activity of some type that we could see with the depth electrode, but in only half of those 10 did we see concurrent seizures consistently on surface EEG. So we know that maxim that surface EEG is going to pick up, electrographic seizures and somewhere around, 20 to 30%. But there may be a whole other third of patients that are having seizures deep in the brain, but because the brain's so metabolically spent and damaged, those seizures can't fully propagate out to the surface where we can see them with conventional surface EEG. Do these seizures drive poor outcome? Do they cause secondary brain injury? Do they lead to depressed level of consciousness and failure to recover from coma? We'll find out one day. But it has been shown here, though, that when you seize on depth alone, in general, the prognosis is much worse with more poor outcomes than when you seize on depth and surface. And we have yet to see any example of somebody seizing on surface without seizing on depth. So kind of a brave new world. Welcome to the future. There are a lot of great reasons to get involved with and look at the fascinating physiology of the comatose human brain using multimodality monitoring. Thank you very much for your attention.
Questions, anyone?
Thank you, Stefan. Very nice as usual. So basically what you told us is a lot of the things we are doing is actually, we're not doing the right thing. We should not fuss around with blood sugar. We should not fuss around with temperature. And maybe we should not be lowering the blood pressure.
No, I wouldn't say that. No, I think what the tools allow us to do, I have another one too with the hemoglobin, and there's less brain hypoxia with higher hemoglobins, which is totally contra to the tricks thing with the hemoglobin of 7, I just think what it does is it gives us more situational awareness, right? It gives us more understanding of maybe unintended consequences of downstream effects of the things that we're doing. And I'll tell you one right now is if you're monitoring PbTO2 in a real blasted out ICH patient that you're fighting for, you're generally going to be using less cardine because you'll see that relationship. Arbitrarily, we say 140. I know, the data from the trials now interact in ATAC, but that's what that information shows. So I'm not saying it's the be all. I'm not saying it's the end all. These are very preliminary observations. None of this stuff is definitive, but it opens up new vistas, right? New playing fields for us to get involved with and make more discoveries.
Okay, one question for you, Stefan. Thank you so much for that awesome talk. Guidelines. Do you think guidelines are actually helpful or harmful? Because, the more you speak about this, and I've seen you speak before, and I've heard other people speak about cerebral autoregulation, it seems like, we've got individualized CPP targets, individualized ICP targets, hemoglobin goals. And sometimes the guidelines just homogenize everything. It seems almost like amateur hour. It's like, hey, let's do this because it's simple, because I don't want to complicate my own life. But for that patient, are we doing the right thing? And the more and more guidelines keep coming out, they oversimplify everything. Is there a time when this is going to change because you've been doing this for a little bit?
Yeah, well, sure. What this allows you to do is individualize. This is precision medicine. So for instance, the ICH data, or let's take the poor grade SAH. If you don't have the monitors, if you believe what you see in about 35 people, right, in general, on average, they have more brain tissue hypoxia when the CPP is below 70. So maybe we could say, if that's shown again and again, in general, right, in the absence of direct information, keep the CPP above 70. If you have the monitor in your patient, though, you don't have to guess. And you don't have to generalize. You can just look exactly what's happening to Mr. Jones this Friday afternoon. And what he's doing this Friday afternoon may be different from what he's doing tomorrow. So it's a totally different level. As far as guidelines go, I want to quote my good friend Claude Hemphill, who, right, to understand, being compliant with guidelines, right, it's nothing aspirational. It doesn't mean you're great or wonderful, right? This is just the basic stuff. It basically means you don't suck. But if you really want to be great, if you want to innovate, right, you got to go way beyond the guidelines. And we need to maintain a culture in academic medicine where it's okay to do that, right? To you know, if we didn't have places that were messing around with brain oxygen, we never would have had enough preliminary experience to even think of doing the Boost 3 trial. Right, so it's kind of got to start somewhere, and you know, we need a sort of more liberal and accepting attitude that it's okay to innovate. Innovation in medicine is incredibly important. If you stifle innovation, right? If my administrator said, "We're not paying for that, no one else does it," right? You're not doing that, right? Then you pretty much put a chokehold on creativity in medicine.
Doctor, given what you just told us, that maybe a third of our patients could be having deep seizures that are not being caught up on the surface monitor, do you think it should be appropriate to do a routine deep seizure monitoring on these patients? And could this be the reason behind why these patients have a higher CPP, well, like an optimum CPP?
Yeah. So could insertion of a depth electrode become a standard of care one day? I believe it actually might. My also good friend and colleague at Columbia did much of this work, and he remains the director of that unit now. Look at his work. It's fantastic. He's able to look at the metabolic consequences of seizures in incredible precision and detail in human beings, something that, you know, in coma patients, no one had ever done that before. And bad things happen. That's all I can say metabolically. So I will tell you that increasingly there's a small number of neurocritical care programs around the country. I know UCLA is one, a few more that have now started to routinely monitor intracortical EEG when they put bolts in. And we intend to do that too. But we just kind of want to go stepwise for everyone. So we're going, you know, PBTO2, we use the Rametic PTO, pressure tissue oxygen, we're adding microdialysis, just through simple dual lumen bolt, and then we'll just keep pushing it. But we want to end up there, yes.
Well, I'm going to drink to that tonight. You know, higher aspirations than not sucking. Our next speaker is Dr. Magdi Salim, following along the same theme of people that I needed a letter from so I wouldn't get thrown out of the US. But I think we all have about 35 minutes to speak. And if I were to speak about Magdi and go through his CV, it's 35 pages long and he wouldn't have any time to talk. So Magdi is amazing. He's a full professor at Harvard, and that basically summarizes exactly who he is. It is impossible to be a full professor at Harvard, but he is. He's going to talk to us about deferrioxamine mesylate in intracerebral hemorrhage. And as we all know, ICH has very poor outcomes associated with it, unlike ischemic stroke, unlike subarachnoid hemorrhage, where we've made tremendous advances in terms of management of those conditions. And the outcomes have changed. With intracerebral hemorrhage, we found nothing, absolutely nothing, that has really worked. And he presented this data over in Hawaii at the ISC recently. But I don't think anyone heard it because everyone was at the beach because it's Hawaii. So this really is the first time anyone's going to hear the results of IDEF. So I look forward to it. Thank you.
Thank you, Niraj, for the kind introduction, and it's really a pleasure to be here. And thank you guys for staying around. It's Friday afternoon. It was the same thing when we presented the data actually at the stroke conference. It was also Friday afternoon. So Niraj wanted me to talk about this. We presented it. The manuscript was just published a couple of weeks ago, so some of you may know the results, but I wanted to take a deeper dive into the results and kind of see what you think. So these are my disclosures, but I have to admit the biggest disclosure is that it's a challenge to speak after Stefan. What a wonderful speaker, very energetic, difficult to beat. And particularly when we're talking about hemorrhage, which we have to give him credit, I think really research in ICH was really started and people got interested in it because of Stefan's work with factor 7. So when we talk about research in ICH, we know that there are different targets that we go after, and for a while, and rightfully so, it was going after the hematoma and its expansion. And this started with hemostatic therapy and factor 7, moved on to the blood pressure lowering with the premise that it would limit hematoma expansion, and now there's some interest in reversal of coagulopathy. But there have been also increased interest in the toxic effects of the blood itself. And we have learned a lot over the last few years that the blood degradation products are toxic to the brain and they contribute to brain injury after intracerebral hemorrhage. And people have gone on this in two different ways. One of them is similar to the concept of the MISTY-3 trial, which is trying to go with minimally evacuation of the blood. Unfortunately, MISTY-3, the results did not really come as many of us would have hoped. We went around this at the same time trying to do it in a medical way, and that's by targeting iron toxicity after intracerebral hemorrhage. So let me give you a little bit of a background why iron. So animal studies have clearly shown that after intracerebral hemorrhage, there is a rise of iron in the brain around the hematoma. And this iron comes from hemoglobin degradation that happens after the hemorrhage. The iron is toxic to the brain because it enters into a series of chemical reactions leading to oxidative stress and cell death through a variety of mechanisms, ferroptosis, apoptosis, and autophagy. In animal studies, also deferoxamine, which is an iron chelator, there have been lots of data to suggest that treating the animals with deferoxamine, and when you can see some of the slides there, I don't know if you can see it or not. Where is the pointer here? Which one? This one? Oops. No, we're completely gone. Here we go. Okay, well, yeah, I'm not going to risk it. But anyway, treatment with deferoxamine, what we see it would do to this is that it reduces actually the cells, the ferritin positive cells around the hematoma. It reduces death, neuronal death around the hematoma. And when you do behavioral testing in animals, it improves outcomes. So it's like the wonderful drug in animal models. And this has been shown in rats and it has been shown in pigs. So many years ago, we wanted to see if we can actually translate this from the animal models into the humans. And we started with several studies, phase 1 and phase 2. And phase 2, as I will explain in a few minutes, we had high def and IDEF, and that's what I'm going to talk about today. So for those of you that don't know what deferoxamine is, it's an iron chelator. What it does, it binds to iron, and by doing so, it prevents iron from entering into these chemical reactions that lead to cell death. But deferoxamine also has other protective effects to the brain. Probably the most important one is that it induces the transcription of heme oxygenase 1. This is the enzyme that's responsible for the degradation of hemoglobin degradation products. It has anti-inflammatory effects, and surprisingly enough, it also has blood pressure lowering effects if you believe that lowering blood pressure in hemorrhage is helpful. It's a generic drug. It's been around since 1960s, so it's very cheap. and we know a lot about its safety profile. So many years ago, we wanted to just ask the simple question, can we use deferoxamine in hemorrhage patients? Is it feasible to use it? Is it safe to use it? And how much of the drug can we give to these patients that are elderly and sick and have many other comorbidities? So we started with the DFO and ICH trial, and basically what we did, we treated patients with very small dose and gradually escalate the dose using something called continuous reassessment method. And what you can see here is that we were able to go all the way up from 7 milligram per kilogram per day. We were given this as intravenous infusion for 3 days. And we kept escalating the dose until we reached all the way up to 62 milligram per kilogram. And we stopped there, and we thought that this was the maximum tolerated dose. The reason we stopped is not because we saw any toxicity or side effects from the drug. We stopped because the package insert and the FDA do not allow you to give more than 6,000 milligram per day. And our patients tend to be overweight, and we were starting to hit this target. So now we figured out it's feasible to do it, it's safe to do it, we know how much we can give. The next question was, what is really the optimal dose? So at the same time, the animal data that looked at the right dose of deferoxamine in animal models suggested that there are 2 doses that were effective. And the human equivalent dose of these was 16 milligram and 32 milligram. So a lot lower than the 62 that we were able to give to the patients. Also in animal models, the question came, what's the duration? What's the best duration to get the maximal effect from therapy? And in animal models, anything over 2 days seemed to be better than giving placebo. But the optimal effect was if you treat the animals for 7 days. So then we came kind of at a tough decision what to do. We know that we can give up to 62 milligram, but we know that the animal data suggests that lower doses are effective. We treated for 3 days, but the animal model suggests that you can treat for 7 days. So do we go with 62? Do we go with 32? Do we go with 16? Do we treat for 3 days or 7 days? So the initial thought is that we wanted to do a dose selection study and a duration selection study. And that was how we submitted the initial grant. We got a quick response from the study section that this doesn't make a lot of sense because 62, you were able to give it to people. There's always this thought that more is better. So you go with the 62 milligram and you have 7 days, go with 7 days. Even though 7 days, you're really biased because you select only the severely injured patients. You exclude a lot of patients. And after some bargaining, we agreed on 62 milligram and 5 days as a happy medium. And we started high def, which stands for high dose deferoxamine in intracerebral hemorrhage patients. And the question that we really wanted to ask was very simple. Is there sufficient evidence to say that deferoxamine does something to allow us to go to a phase 3 trial before we spend a lot of money on a phase 3 trial? So this was a multi-center trial sponsored by the NIH and was 40 sites, most of them in the US and few sites were in Canada. Our main objective, we wanted to see if it's worth it to move deferoxamine into a phase 3 trial. And we wanted to look into this by looking at the outcome or the proportion of patients who have good outcome after 3 months. And we define good outcome as modified ranking 0 to 2, compare it between deferoxamine arm and the placebo arm. And at the same time, because we didn't really treat anyone before for 5 days, because our phase 1 was 3 days, we wanted to look at the safety of this. And quickly, we were lost in translation. So what happened is that we had to stop enrollment after 42 days, 42 patients. And the reason for this is that we started to see cases of acute respiratory distress syndrome piling up. We had 7 patients that had acute respiratory distress syndrome. And the reason why we got nervous about it is this paper on the right side of the screen. This is from the early 1990s in patients who were treated with high-dose deferoxamine for a longer period of time. And these were not hemorrhage patients. These were young patients, mostly have thalassemia. And they developed ARDS. So when we unblinded our patients, it turns out that 6 of the 7 cases were in the deferoxamine arm. So obviously the drug has some lung toxicity that we did not discover in animal models. We did not identify this in phase 1. So we had to go back and revise the protocol. So we did the natural kind of dose selection, duration selection study. We reduced the dose back to 32. We reduced the duration of treatment from 5 days to 3 days because the median time to onset of ARDS in these 42 subjects was around 79 hours. And then we revised our inclusion-exclusion criteria to exclude patients who are at high risk of ARDS. At the time of doing this, the data from MISTY, phase 2 MISTY, were coming out, where Dan Hanley clearly showed that hemorrhage patients continue to improve over time. And even after a year, there are some patients that continue to improve. So we decided to extend our follow-up period from 90 days to 6 months. So it was basically the same study, but now it's IDEF, which stands for intermediate dose deferoxamine, but the same objectives. As I mentioned before, our primary outcome was modified ranking 0 to 2, but we also wanted to look at modified ranking at 0 to 3. We wanted to look at the ordinal distribution across the entire MRS score, and we wanted to look at these analyses at 6 months. Now, this is the design of the study. It's multi-center, double-blind, placebo-controlled, randomized study. 294 patients randomized 1-to-1. Half of them would get placebo and half of them will get deferoxamine. We start the treatment within 24 hours, and we wanted half the patients to be treated within 12 hours and the other half between 12 and 24 hours. The reason for this is that in animal model, there was some suggestion that maybe if you start treatment early, you'll see a better response. And then in order to balance the groups, we decided to randomize the patient based on ICH score, based on their NIH stroke scale when they come in, and the hemorrhage volume, and whether they were on anticoagulation, particularly warfarin or not. These are our main inclusion-exclusion criteria. I'll quickly go through them. Basically, anyone older than 80 was excluded. We wanted to make sure that they have some deficits, so the NIH stroke scale had to be greater than 6. GCS score had to be greater than 6. And then the exclusion criteria is kind of what you see in any other hemorrhage trial. Basically, if they have a secondary hemorrhage, if they were really in bad shape when they came in, if they had coagulopathy. So the only patients with coagulopathy that we included were patients on Coumadin if the INR was less than 1.3. Anyone else was excluded from the trial. Then on the right side of the screen, you see what we added. So these are the exclusion criteria that we added to exclude patients at high risk for acute respiratory distress syndrome. And what we used here is the lung injury prediction score. Basically, we adapted it in order to exclude these patients with hemorrhage who we think might be at high risk for ARDS. Now, this is basically the study design. Patients come in, they're screened. Unlike any other hemorrhage trial, chest X-ray became an important part of our screening process. And then they get randomized, and then we treat them for 3 days. We decided to get imaging after this to look at what happens to the hemorrhage, what happens to the edema. And then we followed them up at 30 days, 60 days, 90 days, and 180 days to look at their outcomes. So I want to talk a little bit about the study design because it was different. So what we used is something called futility analysis, and I'm going to explain what this means. So basically at the end, what we wanted to do is compare the outcome of patients in the deferoxamine arm versus those in the placebo arm. And our hypothesis was that if the difference is less than 12% in favor of deferoxamine, then it's not worth it to move forward. Now, that sounds very ambitious, 12% for modified ranking 0 to 2 in hemorrhage patients. That sounds crazy. How did we come up with that? There were no really positive phase 3 trial for hemorrhage to know what effect size to go under. In my view, the only positive trial we have had for hemorrhage so far is really the phase 2 factor 7 trial. And in this trial, the difference 0 to 2 between the treated arm and the control arm was 12%. So that's where the 12% came in. We also saw that usually when you see an effect in a small phase 2 trial, when you move to phase 3, the effect usually tends to drop. So 12% in this trial would be around 10 or maybe 9% in a phase 3 trial. And that's why we decided to go with the 12%. Now, the 12% was not based on an absolute difference. Because of the futility design, what it means is that your confidence interval will have to include the 12%. So basically what we wanted to see is that there is just a hint that the drug can make it up to this level of an effect size. So that's how the 12% came up. Now for the modified ranking 0 to 3, we made it 13%. And how did we come up with the 13%? That was mostly dictated by sample size and power. This is what our sample size allowed us to look at with sufficient power, so we made it 13%. So what's the difference between the futility design and the regular design? So futility design really is a design that's mostly used in cancer trials. So it's sort of new and not commonly used in stroke or hemorrhage. So in cancer trial, they have lots of drugs. They don't want to do a phase 3 trial for every drug. So they wanted a way to weed out these drugs that look like from the beginning they're not going to work very well. So unlike the usual trials we're used to when we compare two drugs, where our hypothesis that the two drugs are equal, this is the null hypothesis. And if you see significant difference, you say, okay, now we see a difference. The futility design is really different because you start by saying that the intervention is better than placebo. Not only this, but the intervention is better than placebo by a certain percentage, by a certain threshold that you decide what the threshold is. Of course, the lower the threshold, the larger the sample size. So why is this important? Because the futility design really, even if you find that it's worth it to move forward to a phase 3, it doesn't allow you to conclusively say that the drug is better than placebo. So there's still equipoise, we don't know. And because the hypotheses are very different, the interpretation of type 1 error, which is a problem always with multiple testing, is very different. In the usual trials we're used to, when you do multiple testing, people are concerned that you can say that a drug is effective while in fact it's not effective. And the futility design is actually the opposite. You can say that the drug is not futile, but it actually may not be. Oh, I'm sorry, you can say that the drug is futile, but it may not be. So keep this in mind. Now we'll come to the results. These are our baseline data, and I'm not sure how well you can see it, but largely the two groups were equivalent except in few things. And unfortunately, some of these few things may matter. So the placebo group were a little bit older than the deferoxamine arm. The big difference really was in the location of the hemorrhage. So it turns out that the placebo group had around 10% patients higher where they had thalamic hemorrhage, and as a result, they had more intraventricular hemorrhage. So we know that both thalamic hemorrhages and intraventricular hemorrhages are big predictors of poor outcome or associated with outcome. These are the post-treatment characteristics where you look at who got surgery, who got an EVD, who was intubated. We didn't really see a big difference between the groups. And when you look at the effect of treatment on hematoma expansion, edema expansion, changes in intraventricular hemorrhage volume, we also didn't see much difference. These are the safety outcome data. We didn't see any difference. So actually the frequency of serious adverse events with the deferoxamine was less than in the placebo arm. And most importantly, we didn't see a difference in the respiratory problems or ARDS. I think we don't need this. These are the detailed serious adverse events. This is the mortality. Overall, it was low in the trial at 90 days, very similar between deferoxamine and placebo at 180 days, also very low. Now, this is the primary outcome. So this is the modified Rankin 0 to 2 at 90 days. 34% of patients in the deferoxamine arm had modified Rankin 0 to 2. Almost 33% in the placebo arm had modified Rankin 0 to 2. So there was really no difference in the primary outcome, and we can be 100% certain if we do a phase 3 trial using this as the primary endpoint, we're not going to see an effect from the drug. But our secondary analyses are a lot more interesting. So here you can see modified Rankin 0 to 3 at 90 days. And what you see here is that in the deferoxamine arm, the percentage or the proportion of patients that achieved modified Rankin 0 to 3 were 6.2% higher than in the placebo arm. And if you look at the upper bound of the confidence interval, I told you we wanted to reach 13%, and this is just an arbitrary number. We came very close. This was 12.1. So this is at 90 days for modified Rankin 0 to 3. Now you move down here, this is looking at modified Rankin at 6 months, and this is 0 to 2. At 6 months, this is a positive trial. You can see here that almost 9% percentage higher in the deferoxamine arm that achieved modified Rankin 0 to 2 at 6 months. And the upper bound of the confidence interval was 15.6, a lot higher than the 12% than what we wanted. So we had to ask the question, could this be a chance? Is this just kind of a fluke that we see there? So we did a lot of analysis, sensitivity analysis to adjust for everything for this modified Rankin 0 to 2. We used something that Dan Hanley used in MISTY-3, where you adjust for the size of the hemorrhage, the volume of the intraventricular hemorrhage, the location, whether it's thalamic or not. We did it in many different ways, and you see that the results stood out, that still we see a benefit at 6 months. The only thing one that you don't see a benefit is the best worst case scenario, but this is essentially a way that's biased always against the drug. These are the patients that lost the follow-up. We don't have outcome data. And when you don't do this, so in the deferoxamine arm, you always give them the worst case scenario, that they're dead. In the placebo arm, you always give them the best case scenario, which is that modified Rankin is 0. So that's how this works. Now, this is probably the most important slide. And what you see here on the top is the day 90 modified Rankin distribution and the day 180 modified Rankin distribution. Deferoxamine is on top, placebo is on the bottom on every one. What we see here is that the chances of good outcome overall along the entire distribution at day 90 is 10% higher with deferoxamine. At day 180, it's 26% higher with deferoxamine. But what I really want you to pay attention to is not just deferoxamine versus placebo. I want you to compare deferoxamine at 90 days versus deferoxamine at 180 days, and look at the placebo at 90 days versus the placebo at 180 days. What we see here is very interesting, and I don't want to fuss around with the pointer here, but other than the blue and the green, which is people are dead or modified Rankin of 5, everything moves to the left between day 90 and day 180. And because we started with more modified Rankin of 3 in the deferoxamine arm, you can see that by day 180, a lot of them moved to the 0 and 2. And because we had more 4 in the placebo arm at day 90, they moved to the 3 by day 180. So basically, it doesn't matter what patients get. We clearly see that hemorrhage patients continue to improve between day 90 and day 180. So it's the first sign. I think we need to divorce ourselves away from ischemic stroke. I think the 90-day outcome data point for hemorrhagic stroke is really different than ischemic stroke, and probably we should not use it. Now, this is the subgroup analysis. The one on the left side of the screen, this is at 90 days. The one on the right is at 180 days. And what you see here, two interesting things caught my eyes. Although I'm not a big believer in subgroup analysis, but you can see that the drug seems to be more beneficial in women and in African Americans. And I think this is interesting because of the next slides here. So it turns out that there is actually differences in heme oxygenase 1 between men and women and between African American and non-African American. And we have blood samples and we're looking into this in our own population. So in summary, what we found is that treatment was safe. It's very cheap. It comes to around $50 a day for the infusion. It's very easy to get. However, if we go by our primary endpoint, it's not going to work. But we have clearly shown that patients continue to improve after 90 days, and maybe 90 days is not really the right time point to look into this. And our secondary analysis at 6 months clearly shows some signal that it could be beneficial, or at least it's not futile to consider reevaluation at this time point. So what have we learned from this? I think that translation is really very difficult. We tried to follow exactly the data from the rats. It didn't really work very well in humans. You have to adjust along the way. It's becoming very obvious that hemorrhage trials will have to be longer and will have to be larger because the effect size is not very big. And the last point, which I didn't really have time to talk about this, there is a lot of interest now because there are a lot of drugs coming to try to target these effects of hemoglobin degradation products, inflammation after intracerebral hemorrhage. And a lot of these trials are trying to use perihematoma edema as your endpoint. And what I show you here is an example of a drug where you can see some effect on outcomes, but you don't see an effect on perihematoma edema. So I think I would be very careful with using this as an endpoint for clinical trials. Another thing that we learned is that try to avoid British journals, because that's where the paper came out. And basically what they do is that they only allow you to only present the primary data in the abstract. So this is only the primary endpoint, and you can't really, all the stuff that I showed you, you cannot put it in the abstract. So a lot of people just look at the abstract and don't read the paper, and you just read the abstract from the beginning. This is a negative trial, we're done. But what I showed you here is that there is really a lot to think about, and there is a lot of data that really challenges what we already know about intracerebral hemorrhage. So I'll leave you with the question that we started, and you make your own judgment. Do we see any hints or any evidence to suggest that this drug is worthwhile moving to a phase 3 trial or not? And I'll leave this up to you. And I just want to acknowledge a lot of people that were involved in this trial. There was a lot of effort and hard work from everyone. And thank you again for the invitation.
Thank you, Magdi. Questions?
Do you have any theory as to how a drug you give for 3 days would have an effect 180 days afterwards?
Why would it work? So I think that's what I was trying to show you from the data between the 90 days and the 180 days. So the drug did something at the 90 days because the 0 to 3, we saw a difference. But I think it takes time for the patients to recover. I think after hemorrhage, you have a lot of edema, you have a lot of intraventricular hemorrhage, you have ICB. So it's kind of jump-started the things, but it was not big enough to see an effect at the 90-day period. And it takes time for this residual effects to kind of resolve to be able to see the difference.
But the drug itself had been cleared and it's not continuing activity.
No, of course, it has been. It's like a jump start, sort of.
So Magdi, what are the next steps for you in terms of deferoxamine?
So we're really struggling with this a little bit. So of course, the easiest way to say, we're going to go back, do the same thing, but look at 180 days and probably put an early stop to try to replicate the futility early on. And if you see a positive signal, move and complete the trial. If you don't see it, you stop. I'm personally thinking that probably the right way to go about this, it's naive to think that one intervention is going to work very well. And if it works, the effect size is very small, as you can see. So I'm really interested in combination. And I think what we learned from MISTY-3 and from this is that both of them, you can see some effect, but it's not strong enough. And I wonder if combining, trying to evacuate the hematoma to reach to a certain threshold with deferoxamine, I think that probably you might get a bigger effect for the intervention.
Thank you. Thank you, Magdi.
Okay. Thank you.
Thank you again. We're going over just a little bit, but that's fine. There's always time to drink. My next speaker is Dr. Matthew Koenig, or as I call him, Matt. Matt and I were co-fellows about 15 years ago. Matt Koenig is also my friend. Matt Koenig also knows enough about me that someday when I have a tombstone, he can scribble whatever he wants on that. It's probably going to be true, but he probably don't want to read it. I had a hard time trying to figure out like which speakers to pick, and I was so honored that we had Magdi come and we had Stefan come. But what I had, in my favor was that they were coming from the Northeast and the weather's so much better than Florida. I was like, man, if they come for nothing else, they'll come for the weather. Matt and Jen, who spoke at the nursing symposium, are coming from Hawaii, so for them it's actually a downgrade. So, so I'm so thankful that they came. Matt also helped me gain some perspective in life. Like I said, we're co-fellows, but he is way smarter than I am. So it made me very comfortable in my own skin. It's okay to be mediocre, just be you. But I am glad that someone smarter than me is coming up here to speak next. So Matt's going to talk to us about cardiac arrest. Thank you.
Thanks, Neeraj. And it's true, I know a lot of dirt about Neeraj, but he has a lot of dirt on me too. And, mutually assured destruction is a good basis for a friendship, I think. Let's see if I can figure out how to use this laser pointer. It's not that hard, Magdi. It's not that bad. All right, so a home stretch here, and I'm going to be talking to you about cardiac arrest, a little bit about ICU management of patients who have survived cardiac arrest, and a lot more about monitoring and prognostication in these patients. These are definitely some of the sickest and most challenging patients that we care for in the neuro ICU. And it can be rewarding in some cases, but a lot of times these patients have poor outcomes, and it can be very difficult on staff and very time consuming and emotionally draining to care for these patients and their families as they struggle in making decisions about where to go and what the chances are of these patients recovering. And a lot of what we do in neurocritical care is really guiding those decisions and trying to use the best data that we can to determine if patients are going to recover, what sort of recovery to expect, and then guide families through that process. So I think this is a really important part of what we do in neurocritical care. And so I'm honored to come and talk to you about this topic. I don't have any disclosures except to say I spent 4 years at Johns Hopkins inducing cardiac arrest in rats and then resuscitating them and monitoring recovery of the brain during that process. So I have murdered many rats in an endeavor to study this disease process. Okay, this is a very frequent condition that we treat. And it's even if as a neurointensivist, we don't directly care for these patients in our ICU, not all neuro ICUs do that. But even if we're not directly caring for these patients, we're very often consulted for prognostic purposes or to assist with management of these patients. And almost all patients who survive a cardiac arrest are initially comatose. And so the nature of the consult is generally what are the chances that this person is going to recover from coma beyond just a vegetative state? What is the chances of the patient recovering? And the data is pretty grim. If you look at all comers who have survived a cardiac arrest, fewer than 10% of them are discharged from the hospital neurologically intact. But if you look at case series and clinical trials that have been completed, the data is a lot better in patients who survived to be admitted to the hospital and were managed in an intensive care unit with full care for full supportive measures. You can see published data as high as 60% of patients eventually making a good neurological recovery at 6 months. And so the data can be grim overall, but patients who make it to the ICU and are aggressively managed, as many as half of those patients can ultimately have some good neurological outcome. Cardiac arrest is not stroke. It's just a different animal altogether. Stroke is really in most cases, permanent occlusion of a blood vessel and ischemic injury to part of the brain as a result of that permanent occlusion. Cardiac arrest is a different model of ischemia. It's a no-flow, reflow model, meaning there's a period of time when there is no brain perfusion and brain tissue oxygen effectively drops to zero. And then when the heart is resuscitated and the blood pressure is restored, there's reperfusion of the brain. And because of that disease process, the injury to the brain is very different from stroke. Rather than seeing wedges of infarcted tissue the way you do in stroke, you more typically just see bland necrosis of neurons. And these neurons just drop out and the injury is on a cellular basis. And there's selective vulnerability of different parts of the brain. The large, very metabolically active projection class neurons in the deep cortical layers and in the hippocampus are selectively vulnerable to this disease process. And why are those important? They're important because those are the underpinnings of the network functions of the brain. Those are the neurons that control our cognitive processes, our memory, and really are the underpinning of consciousness. The activity within cortical networks and thalamocortical networks is really what is the underpinning of consciousness and cognitive function. And so patients who have survived cardiac arrest have a constellation of problems that gets referred to as the post-cardiac arrest syndrome, and results in cognitive dysfunction and very selectively is involved in encoding memory, and the hippocampal processes involved in memory encoding. And even patients who have survived well or have recovered well after cardiac arrest very commonly have cognitive dysfunction and very, very commonly have difficulty encoding new memories. There's also a movement disorder that's very characteristic of the post-cardiac arrest syndrome, which is an action-induced myoclonus called Nance-Adams syndrome. And together, those make up the post-cardiac arrest syndrome. I told you I spent 4 years inducing cardiac arrest in rats, and I spent 4 years also kind of proving to ourselves that cooling the body temperature of the rat after cardiac arrest improves outcomes. We did electrophysiological monitoring of the brain and looked at network activity of the brain during rats who are normothermic and rats that were cooled. And I have numerous publications showing how effective this is in rats. So Magdi and I can sort of commiserate about the translation of that as well. And I'm not going to spend a lot of time talking about what the ideal target temperature should be after cardiac arrest. There's debates sort of raging about that now. But I will show you that the TTM study that was published a few years ago that effectively found that patients who were managed at 2 different target temperatures, 33 degrees versus 36 degrees, had similar outcomes, had similar mortality, and had similar cognitive recovery or functional recovery at 6 months. Patients who are managed at both of these temperatures. And so the current guidelines really reflect the options of different target temperatures, and the guidelines suggest a range of target temperatures between 32 and 36 degrees. The TTM2 study is ongoing, and it's at about 500 patients enrolled so far, and that study will look at 33 degrees versus 37.7 degrees, which really is not hypothermia. It's a comparison of hypothermia versus fever control. And so it'll be really, really interesting to see what the result of that trial is when it comes out, and probably in about 2 years, we'll know the results of that. The other clinical trial on post-cardiac arrest management that I'll draw your attention to is the early goal-directed therapy for cardiac arrest patients. And this was just published about a month ago. And the study looked at early goal-directed therapy, very similar to what was done in sepsis. Maintaining a mean arterial pressure greater than 85 and an SVO2 of 65 to 75% versus standard therapy, which is a mean arterial pressure greater than 65. That's the standard therapy that's in the guidelines. And they randomized, it's a relatively small trial, but it was a well-designed randomized controlled trial, randomized 112 patients. And they looked at functional outcomes. They also looked at an MRI marker of ischemic injury called the ADC score. I'm going to show you that in a little bit. And then they also measured cerebral oximetry in this study. And what they found is that patients in the early goal-directed therapy versus standard therapy, they did maintain a higher mean arterial pressure. In the early goal-directed therapy group, they used more vasopressors here. And they did actually increase the cerebral oximetry of patients as a result of that. And they did also use TCD to measure MCA blood flow to the brain. And they did augment blood flow to the brain when they elevated the blood pressure and maintained a SVO2. However, outcomes were not affected by that, surprisingly. And the outcome that's used is a CPC, which is like a Glasgow outcome score. Basically, lower scores mean less brain injury, were the same between the two groups. And then the ADC score using the MRI marker of ischemic cortical injury was the same in the two groups. Okay, moving on to neuromonitoring and prognostication. The real crux of prognostication is multimodality, really. And it depends on the clinical findings based on the neurological examination and also biomarkers. EEG and SSEP are commonly used electrophysiologic tests. And I would say a couple of years ago, I wouldn't have put imaging studies on this, but imaging studies have really become part of how we prognosticate in this disease in a way they were not in the recent past. The American Academy of Neurology released a guideline back in 2006, which has been the standard for how we prognosticate, when we prognosticate, what tests are done, and what those prognostic markers mean in this population. And what I'll say about this algorithm is that it's outdated and really is in need of update at this point. And at the end of the talk, I'll show you the European guidelines, which I think are more contemporary. But I will show you this because it is the current guideline from the American Academy of Neurology. And when we talk about prognosis in cardiac arrest, almost all prognostic studies that are done are negative prognostic studies, meaning how do we predict who will not recover? You know, what are predictors of who will not recover? Very little research has been done to look at early prognostic markers of people who will recover, of good prognosis. So this is no different. The AAN guideline really looks at tests for people who will not recover after cardiac arrest. And it's based on absence of brainstem reflexes, myoclonic status epilepticus, and then absence of cortical transmission in electrophysiologic tests using SSEP, a serum biomarker called neuron-specific enolase, and then at 3 days, absence of cranial nerve reflexes and absence of motor movements that are better than posturing. So either no movement or extensor posturing. So the clinical examination is part of every prognostic test in cardiac arrest survivors. And the elements of the clinical exam that are most important are, of course, arousal and consciousness, cranial nerve reflexes, including pupillary reflexes and corneal reflexes, looking for motor response, either extensor posturing or no movement, examining for post-anoxic myoclonus, and looking for epileptic seizures. Part of the problem, and one of the reasons I say that the AAN guideline is outdated, is that it looks at motor responses at 72 hours. And one of the concerns in the hypothermia era, whether that be 33 degrees or 36 degrees, is that medications are needed to, as Stefan mentioned, suppress shivering. And sedative medications are needed to suppress shivering. And that can really mask the motor exam, and there can be delayed metabolism of those sedative medications. And so there's a lot of concern that you would have a falsely pessimistic prognosis based on the motor response alone at 72 hours in patients who are treated with hypothermia. And that is really borne out by the literature. This is, you know, in addition to the TTM study showing that 36 degrees had equivalent outcomes to 33 degrees, there have been about a dozen subsequent publications looking at the effects of prognostic testing in the patients who are enrolled in this study. And looking to see if hypothermia altered the prognostic value of those tests. And so the motor score is the one that really shook out here. What I have highlighted over here is the false positive rate. And so the GCS motor score less than or equal to 2, that's extensor posturing or no movement with stimulation, has a false positive rate as high as 40% in patients, really in both groups of hypothermia managed patients. Okay, post-anoxic myoclonus is something anybody who's taken care of post-cardiac arrest patients, I think, has probably seen this. It's a very dramatic presentation. Patients have trunk predominant stimulus-induced myoclonic jerks, really of the whole body. They can be very severe and can actually interfere with the ability to ventilate the patient. They can be so severe. And for families really struggling with decision-making of their loved one who's in a coma, who survived this cardiac arrest, these can be very, very disturbing to see this, and for caregivers as well. They're not considered seizures per se, although I think with what Stefan showed with depth electrodes in patients who have burst suppression EEG, he might argue with me on that point. I wonder, I don't wonder. I'm very, I'm pretty convinced that if you put a depth electrode in these patients, you would see seizure activity during these events, but we don't call them seizures. In a lot of ways, it's inconvenient to call them seizures, because if you call them seizures, then you have to treat them, and they're very, very hard to treat. They're very treatment refractory, and you're going to end up with a lot of barbiturates in these patients. And if you give barbiturates to these patients, then you're not going to know if the patient's going to wake up for like a week. And so I think a lot of it is a willful sort of, if you can't stand the answer, don't ask the question, right? So, but they're not considered quote unquote seizures per se. They are very prognostically important. And that is something that has persisted in the literature, which is that a tick of myoclonus here and there during the first 24 hours really has no prognostic value in these patients. So if you see a little myoclonus during the first day, that's not this. This is persistent myoclonic status, meaning frequent stimulus-induced, very stereotyped myoclonic jerks that persist for greater than 24 hours. That has remained very prognostically important in that it has very high specificity for poor outcomes in these patients. Okay, a word about neuron-specific enolase. I don't personally test this as a prognostic marker in cardiac arrest survivors, in large part because in Hawaii it's a send-out test and it takes a week to come back, and that has no value to me. So I don't have a lot of personal experience with NSE. It did make it into the AAN guidelines at a cut point of 33. Meaning if it's higher than 33, patients will not recover. But there was a lot of controversy subsequently, especially in patients who are managed with hypothermia, that there could be false positives at that cut point. So I've seen other publications suggest 50. I've seen others suggest 90 as a more accurate cut point. And it's also time dependent. So if you test it on day one, basically NSE is released into the serum because there's a lack of oxygen to the brain or a lack of perfusion to the brain, and then restoration of perfusion. And so there's a delayed rise, and if you test it during the first day, you may not actually catch the rise of it. And so day 2 or 3 tends to be the peak in patients, and it's better tested on those days. Okay, this is also from the TTM study, basically looking at this question of, does hypothermia in and of itself increase NSE, as some publications had shown? And at least in this study population, it did not. And NSE continued to maintain its prognostic value in hypothermia managed patients. Okay, some words about electrophysiological testing for prognostic purposes in these patients. The 2 main tests that we do for prognosis after cardiac arrest are EEG and somatosensory evoked potentials. And we test those because they do what I did in the lab with rats, which is measure the network function of the brain. The cortical thalamic loops, or the thalamocortical projection of electrical information into the brain, is measured by EEG in part, and mostly by somatosensory evoked potentials. And the negative patterns, or the malignant patterns of EEG that we see in patients who have survived a cardiac arrest, are low entropy states. Whereas the brain, typically when there's network function of the brain, the electrical activity that we see has high entropy. It's variable, it's reactive. Like if you stimulate the patient, there's a change in the EEG that you can measure. Whereas when there's a injury to the brain and network activity of the brain is lost, then the brain becomes much more rhythmic or periodic and less entropic and not reactive to external stimulation. So the classic kind of malignant patterns that you see that have poor prognostic information are electrographic seizures, what's called burst suppression, which is alternating periods of EEG suppression and abnormal activity. Non-reactive EEG patterns, EEG that does not change with external stimulation. Here's an example of burst suppression. The one on the left is actually anesthetic burst suppression. The one on the right is actually burst suppression induced by anoxia. They can look similar, but these are alternating periods of EEG suppression and then bursts of EEG activity. Electrographic seizures also have a poor prognosis, but the prognostic value of them really depends on what they emerge from. And this is another kind of, another sort of danger point, which is that not all electrographic seizures in patients who have survived a cardiac arrest portend the same poor prognosis. It really depends on what that electrographic seizure emerged from. And this is where continuous EEG is really, really important in patients who have been resuscitated from cardiac arrest. What is the initial rhythm that you see? What does that rhythm evolve into? And if there are electrographic seizures, what did those seizures evolve from? Did they evolve from burst suppression and then the bursts become continuous and then they become seizures? Or did the patient go into a reactive EEG first and then go into seizures after that point? And you can't really get that information in retrospect if you just put in the EEG on somebody for prognostic purposes on day 3 and you see that they're in status, right? So you don't really have the information of what that status emerged from at that point. Some examples of, this is actually from my friend Peter Kaplan at Hopkins, and we've published quite a bit on electrophysiology for prognosis in cardiac arrest patients. And Peter published a series of 6 patients who awoke and had good neurological outcome after cardiac arrest despite having status epilepticus. But it really kind of drives home this point of what did that emerge, who is that patient, what is the context of that electrographic status? And the things that I highlight here are that all of these patients had preserved brainstem reflexes. All of these patients actually had EEG reactivity. Not only was the EEG continuous and not burst suppression, the EEG was reactive to external stimuli before the status epilepticus developed. So this is a different animal, and all of these patients had cortical responses on the evoked potentials as well. Okay, what are the issues with EEG? There's, certainly EEG is affected by sedation, right? So if you need sedation to suppress shivering, the EEG can be greatly impacted by that, and the prognostic value, especially the reactivity of it, right, or the variability of EEG, is really suppressed by sedation. And so you have to be careful with using EEG for prognostic purposes in patients who have been recently sedated to suppress shivering. There's also a question about timing, the timing of the prognostic value of EEG with respect to the cardiac arrest. And there's a lot of borderline patterns, as anybody who's done ICU EEG knows that there are a lot of different patterns that are on the interictal spectrum, and it's not clear what their prognostic value is. This is not a human, this is a rat, actually. This is a 2-channel EEG in a rat. And it shows something that I want to highlight, which is that this is a baseline EEG in the rat. This is the EEG of the rat during cardiac arrest. And then after resuscitation, the first thing that you see is a return of burst suppression. So burst suppression beginning here, and then the bursts become more frequent, and then the bursts merge into a continuous EEG, and then the EEG becomes reactive. And if you put EEG on a patient who's resuscitated from a cardiac arrest early enough, you will see the same pattern. Every single patient who's been resuscitated after cardiac arrest goes from complete EEG suppression to burst suppression, more frequent bursts, continuous EEG, then variable reactive EEG. And it's a question of when you put the EEG on that patient and how quickly the patient gets out of burst suppression into a continuous rhythm. That has the most importance. So if you see burst suppression EEG on day 1, that doesn't mean the patient is not going to recover. If you see burst suppression day 3 or a week into it, that's a different story. So examples of this in humans, not in rats, showing a patient going from burst suppression during the first day to a continuous EEG the following day. Somatosensory evoked potentials are an electrophysiological test where the median nerve is stimulated in the arm, and then conduction of that electrical stimulation is monitored through the neuraxis, through the peripheral nerve, through the brachial plexus, the cervical spinal cord, the brainstem, the thalamus, and the cortex. So this is a typical normal median nerve SSEP. The N8, what's called N18 by convention, this is monitored on the scalp, and this is a thalamic potential, and then a cortical potential in the primary sensory cortex. These are early latency cortical potentials. N35 is a middle latency potential, and then there are longer potentials as far out as 70 milliseconds after the stimulus. And these early potentials reflect thalamic, primary sensory cortex, and then intercortical network processing of that sensory stimulus. Examples in cardiac arrest survivors that I've seen, this is normal. This is how it should look. You see a robust N18 and N20 on the cortical leads, reflective of intact thalamic to cortical projection of the stimulus. This is what you don't want to see, which is the complete absence. Everything's intact in the periphery here, peripheral nerve, cervical spine, but there's no cortical or thalamic projection of that stimulus. And when this is seen 24 to 72 hours after cardiac arrest, it's a very highly specific poor prognostic sign that there's too much thalamic and cortical injury. There's no network activity in the sensory nervous system, and the patient is not going to wake up from the injury. Okay, a lot of times you get this though, which is difficult to interpret. These are not normal, but also not absent. SSEP is less affected by sedation. These are done as part of intraoperative monitoring in patients who are under general anesthesia. So they're less impacted by sedation compared to EEG. Timing is an issue though, and there are ongoing concerns that hypothermia might delay or suppress cortical transmission of SSEP. But again, data from the TTM study basically showed that the false positive rate of absent cortical EPs remains very, very low. And so even in hypothermia treated patients, EPs remain one of the most accurate and reliable negative prognostic markers. A few words about neuroimaging. There's actually some studies looking at plain CT as well, looking at loss of gray-white distinction in plain CT. But a lot of studies have come out in the last few years looking at different MRI techniques as a prognostic marker in these patients. And often, even in patients who have very poor neurological outcomes and are comatose, when you get an MRI, you see nothing because it's that bland kind of cellular level necrosis that I showed you. And so not seeing any cortical injury doesn't necessarily mean the patient is going to recover, but seeing cortical injury on MRI, there's emerging data showing that that does have prognostic accuracy as a negative predictor. And these are some examples looking at FLAIR, diffusion weighted imaging, and absolute diffusion coefficient, or ADC. Some more examples of cortical injury. Some authors have tried to semi-quantitatively or ordinal, I guess, prognosis using a MRI score in patients with cardiac arrest, and have showed that patients with these two, either in combination of cortical injury and basal ganglia or cortical injury alone, has very high specificity for poor outcome, or patients are not going to recover after cardiac arrest. And then the Stanford group, and Stefan Mayer was actually a co-author on this as well, and Greg Albers as well, two speakers at this conference, has done a lot of work looking at quantitating the diffusion, the restricted diffusion, using ADC maps and quantifying the amount of ischemic injury to the brain. And so this dark signal that you see in the cortex on the ADC maps here, and quantifying how dark it is. And this is very, this is similar to what is done with the rapid ischemia view software, That uses a cut point of less than 620 as ischemia. This uses less than 650. But if greater than or equal to 10% of the brain has low diffusion in the cortex, that has very high specificity for poor outcome in these patients. There's no perfect test. So there's no one single perfect test that tells you, okay, I can be 100% certain that this patient would not recover beyond a vegetative state based on one biomarker. And so there's a lot of interest now in taking this very large body of literature, prognosis and cardiac arrest, and combining it into multimodality prognostic markers using a combination of EEG, somatosensory evoked potentials, and the neurological examination. And that really has led to the 2015 guideline produced by the Europeans in the ESI, the European Society of Intensive Care Medicine, released this. And this is what I use when I prognosticate in patients who have survived cardiac arrest. I don't use the AAN guideline anymore. I use the ESICM guideline. And I don't know if, I hope you guys will have access to the slides, because the next two slides I took from the ESICM guideline and collated this in a way that I think makes the most sense, which is looking at the false positive rate for all the various prognostic tests at 24 hours and 72 hours, hypothermia or no hypothermia, and also the sensitivity of those tests. And I think that's the information that you really want to know, is how sensitive is this biomarker for poor outcome, and what is the false positive rate of this biomarker. And so I hope that you get access to the slides, and these next two slides are worth taking a look at if you do any prognostication in this patient population. This is the ESICM algorithm. And really what the guideline tells you in Europe is manage the patient aggressively for 2 days, get them through the hypothermia and rewarming period, and then on day 3, begin your prognostic testing. And it's kind of like the Chinese menu approach, where it's like 2 out of 4. You have to have 2 out of 4 bad biomarkers, and then you can prognosticate with a very high degree of certainty and a low false positive rate. And so what they recommend is looking at brainstem reflexes at day 3 and absent N20s, which are the cortical responses on EP. If those negative prognostic markers are both absent, meaning the patient has reactive pupils and has corneal reflexes and has cortical N20s, then wait another 24 hours and then do the next step if the patient has not woken up or begun to wake up at that point. And then look again, look for, did the patient have myoclonic status during the first 24 hours? That's where NSE comes in. That's where your EEG comes in, and potentially your neuroimaging come in. And if the patient continues to remain indeterminate, meaning they have not woken up at what is now 3 to 5 days, but they lack these very specific biomarkers, then they fall into this indeterminate prognosis group, and it's reasonable to continue to manage those patients aggressively to see if they will subsequently wake up. There has been some research into favorable prognostic markers. Everything that I've showed you so far is actually negative prognostic markers, but how do we test to determine, hey, this patient is worth aggressive management? Because these are very sick patients. They often have balloon pumps, they need coronary angiograms, they need a lot of ICU monitoring. And so we don't just want to select out the patients who are not worth continuing that management. We really want to identify early on who has the high potential to recover and is worth this investment of all these resources, and also correctly messaging to the family as well. And so there has been a little bit of research looking at positive prognostic indicators, but certainly not as much as negative prognostic indicators. The easiest one is the patient wakes up, right? If the patient wakes up and becomes conscious, that obviously has a lot of good prognostic value. But the other good one is early EEG reactivity. And so here's an example from the literature showing that kind of what I showed you in rats, which is that it's not just, is there burst suppression? Yes, no. It's how did that EEG evolve during the very early period after cardiac arrest. So this patient up here who had a good outcome, 7 hours after the injury, it has burst suppression, but by 19 hours, it's all continuous. And by 70 hours, it's not just continuous, but reactive and highly variable, right? So the patient had burst suppression early on, but quickly moved out of that into a continuous EEG pattern that became reactive. Whereas the patient in the bottom panel who had poor prognosis remained in burst suppression at 24 hours. And then EEG eventually became continuous and disorganized, but was not reactive and did not have high variability. And so these authors found that EEG that became continuous, that was no longer in burst suppression, but it was just continuous EEG activity by 12 hours, has a pretty good has very high specificity for good outcome. And this is just another reason to do early continuous EEG monitoring in these patients to determine not just are they in burst suppression, but how quickly do they emerge from burst suppression and what does that EEG evolve into? There's been some interest in looking at longer latency somatosensory evoked potentials beyond 35 milliseconds, a few small publications on that topic. Some authors, particularly in Europe, have looked at cognitive potentials or what are called event-related potentials, looking at cognitive function or cortical network activity, not just a response to a sensory stimulus, but more complex processing of that sensory stimulus. And then there's been work that I did looking at functional MRI in these patients. And fMRI in the resting state in patients who are not given a task, we're basically told, the patient is told just sit there. There's not a task associated with the fMRI. There's been a lot of interest in looking at what's called the default mode network, which is sort of the idling function of the brain. It's often the part of the brain that's active during introspection when patients are just lying there thinking. And introspection is sort of an underpinning of consciousness. And so there's been interest in looking at the default mode network in these patients who are seemingly unconscious, but are laying in a scanner getting a functional MRI. So I worked with Thomas Ernst and Linda Chang, my mentors, in a functional MRI lab at Queens Medical Center in Honolulu. And we looked at resting state default mode functional MRI in these patients. And this is what you see typically in fMRI, this kind of triangular pattern of activation of some of the deep cortical and deep gray matter structures of the brain. And what we found is that all these patients were initially comatose after cardiac arrest, but patients who ultimately recovered consciousness and had good outcomes had preservation of that default mode network activity, whereas patients who had poor outcomes really had loss of the default mode network activity. And there was a fairly linear relationship with the amount of network activity within the default mode network and outcomes using the CPC as the outcome measure. So that has been replicated in other groups in another publication, but I think it still requires more work before it's going to make it into the guidelines. Okay, and then finally, the timing of prognostication. When is it appropriate to definitively say the patient is not going to wake up? Because patients who kind of fall off that ESICM algorithm, the question is, well, at what point do you stop and say, we've waited long enough and this person even in the absence of negative prognostic indicators, we've waited long enough and the patient has not recovered has not awoken, is not opening their eyes, and is not showing signs of consciousness. And these are helpful data, I think, to guide us as the treating team and also to guide families of saying, okay, at a week, this data is from patients who awoke, right? All these patients woke up after cardiac arrest in this study. The question was, when did they start showing signs of consciousness in those patients who subsequently woke up? And so if you get to 7 days and the patient has not awoken, there's a 2% chance of subsequently waking up beyond that point if the patient continues to be managed. And I think that's important information for families to have and for the team. And so with that, I'll go ahead and end and say mahalo and see if you have any questions for me. Thanks so much.
Thanks, Matt. Awesome talk. A couple of questions actually that are clinically very relevant to us. One, in terms of the decision of 33 versus 36, I wanted to know what your practice was. So if you've got someone that, let's say, is in status post-cardiac arrest or has global cerebral edema, do you favor more aggressive hypothermia in those patients, or how do you decide?
So I as you know, I spent years killing rats and cooling them, and really was very, very convinced that hypothermia was neuroprotective in these patients. And so when the TTM study came out, for about a year, I was in denial. Like, I didn't even want to read it. Right? I was just in denial. I couldn't believe that it was negative. I mean, you could argue about whether it's a negative study, but I was very surprised. And yet I wrote the hospital's TTM policy, and I changed it subsequently after that to 36. And I had the sort of, I guess, displeasure of caring for a colleague of mine who had a cardiac arrest. And I had this sort of crisis of conscience where I had to think, okay, this is somebody that I work with and know and care about. Maybe I should cool him a little more, right? But we managed him at 36 degrees, and that really is what we have done. And so I don't really think there's data to guide selecting some patients for more aggressive cooling. I just don't think we're there. There's clinical trials coming out. There's a clinical trial that compares, I think, 32, 34, and 36, or maybe it's even lower. I think it's 31, 33, and 35. There's 3 arms to it. And that might kind of parse it and give us more information. But I think until we do that point, what I have done and what our institution has done is cool everybody at 36 degrees.
The other question I had is a study that compared a MAP goal greater than 65 versus 85 with a hemodynamic augmentation. It was a negative study, but on the flip side, do you think there is potential harm in patients that have lost their ability to, like, auto-regulate, but maybe you need to cap a blood pressure at a certain number because we just let it go? Now, I know initially we don't worry about it because they're typically a little hypotensive on a bunch of meds, but later on, do you say, okay, individualized therapy? Or
yeah, it's a negative study in that the primary outcome measure, which was cognitive or functional outcome and mortality, were negative, but some of the parameters that they studied, like cerebral blood flow and cerebral oximetry, were elevated in that early goal-directed therapy group where the MAP was augmented to 85. And I'm not sure what to do with that information. I mean, it's not robust information that would make me push everybody to 85, but clearly it had effects on cerebral perfusion and oximetry, and it shouldn't be ignored. I think we need more study there. That's where getting into more, that was all done non-invasively. It was done with
NIRS.
Yeah, I think it was done with NIRS and TCD. It would be interesting to look at invasive monitoring like Stefan showed with multimodality monitoring, and really do some more precision medicine with the parameters that we choose in these patients and see if that has an impact. So it's negative, but I think it's negative, but it generates a lot of interesting hypotheses and data.
Any other questions?
Thank you for the talk.
He's got a question, I think. These guys just want to get in the bar line.
So my question is, now with the TTM trial basically showing that the 36 and 33 are probably equally efficacious, there used to be very strict criteria for people undergoing hypothermia after cardiac arrest. And one of them was that timing issue, like 6 hours from the ROSC. So now that when we get consults on patients who are already like 12 hours or more, and by somehow the decision was not to do hypothermia or even to 36 on them, in your experience, would you still recommend cooling them to 36 at least? And what is the cutoff? Like, is it 24 hours or?
Yeah, absolutely. I mean, and this is a big problem, really, with backing off from 33 to 36. And there are actually studies that show this in a sort of before and after intervention study methodology, is that patients got worse. And they got worse because intensivists got lazy, basically. So, and patients came in spontaneously hypothermic, quote unquote, or already at target. Let's say the patient was 35 when they came into the ER. So we don't have to do anything. They're like already spontaneously at target. And what happens when I go and see that patient like later that day in the evening is they're like 38.5. They're not at target temperature. And so I think the message got out in the wrong way, that the TTM study is negative, quote unquote. Therefore, you don't have to do anything. And a lot of those patients are actually febrile, which we definitely know is harmful. That's clearly harmful to patients. So what I would say is for hospitals like us who changed their institutional guidelines and said we're going to do 36 degrees, it has to be messaged appropriately that that is active management. Like that is targeted temperature management at 36 degrees. And the patients need this, whatever you did for 33 degrees, they need all that same stuff for 36 degrees, whether that's surface cooling or invasive cooling, and an aggressive anti-shivering regimen. They should be managed the same way. So just, you have to be careful about how that's messaged within your institution.
Another quick question is, like, let's say for the initial CT scan, sometimes you have like maybe some edema on the brain. One of the questions is, should you treat it with hyperosmolar therapy at that time, or you already know that there is an oxic injury and that's why there is swelling, and probably it's going to be futile to use any hyperosmolar therapy?
Yeah, I personally don't. I don't do a lot of osmotic agents in patients who have widespread cytotoxic edema of the brain. I really don't think it's effective. So, if a clinician gave a dose of mannitol to that patient, I wouldn't necessarily fault them for doing it, but I don't personally think that it's effective to do that.
Thank you.
All right, thank you.
Usually the onset of seizures tend to be more when we hit the target temperature of 36 or 37, patient are dewarmed. Have you noticed there's a trend of frequency of seizures, and when do seizures occur after switching your practice?
Yeah, we haven't studied that. I mean, anecdotally, I would say I have not noticed that, but I also have not studied that. And it would be worth taking a look at that. Thanks.
All right, I know it's a long day. You guys are all tired, but please remember there's a reception to follow. And for those of you that want to go home and sleep, I'm going to quote Matt Koenig when I've been out with him at around 2 in the morning, saying, "Dude, I got to go and sleep." And his response usually was, "You can sleep when you're dead." So it always worked, trust me. It never left me in a good place, but yeah, still alive. All right, our next and final speaker is Dr. Freeman, Dave. Again, we've had Dr. Freeman come and talk here before from Mayo Clinic. When I look at people, I look at them as a package deal, right? You've got good things, there's bad things. So sometimes you've got people that are incredibly smart, but man, I can't stand them as human beings. There's other people that are really nice people, but they're a little dumb. And there's people that aren't too smart and they aren't too nice, but they got a good sense of humor, like they make you laugh. Right. And so the problem in life sometimes is, getting, and I'm not drunk yet, by the way. The problem is when you think about people as, the Venn diagram, you put those 3 circles together, there's very few people that intersect where, with like that N of 1 that will finally be just right. So Dr. Freeman, ladies and gentlemen. What was that again? Dr. Freeman, ladies and gentlemen.
That's an incredibly hard act to follow, Niraj. Thank you. So I am delighted to speak and echo my colleagues with esteemed colleagues. I'd like to thank Niraj, Ricardo, and Eric. Really a beautiful location, incredible speakers and topics. So, and I do realize I stand between you and the bar, so I'm going to move quickly. And I do appreciate being able to speak on one of the multimodal topics to help speed along, which is around lasers and things that I actually reminded me that I opened up several gigabytes of data that Ricardo and I did together. And I'm happy to email you guys. I gave all my slides and info just for time, so sit back, relax, and enjoy. I'm going to zoom through 3 simple objectives. One is really simplify the physics of how it works and how it measures non-invasively brain oxygenation. Secondly, I'm going to go over some literature, but really give you a case about subarachnoid hemorrhage, which I'm passionate about. And I'm going to go over some pros and cons because it is only one gauge or tool that you have in the neuro ICU. yes, I love mathematics and physics, but I'm going to give you really what I think is the basis of near-infrared spectroscopy or NIRS. So in the upper left, this is Franz Jobsis. He was a Duke scientist. He published in the journal Science using cat experiments. We've all done this before where we shine a light under our head and we see photons, right, permeate tissues. It's actually a brilliant idea because you can measure the optical density units, OD units, and their spectral pattern through tissues is how you measure what we call chromophores. And these are light absorbing molecules in the human body. And the two most common chromophores that absorb the most NIRS light are hemoglobin and cytochrome A3, which is the electron transport chain. So brilliant scientists shown there, and you can see in the bottom left the differences in the NIRS absorption spectra. The way you calculate the difference in optical density units is known as the Lambert-Beer law. It's a perfect segue, right, to the beer that's going to follow this session. Now to go over some important equations, you don't need to memorize these now, but these will be in your handout. Dr. Meyer went over CPP, and from Ohm's law, you can derive cerebral blood flow. You can also do some algebraic manipulation to derive what's called the metabolic consumption rate of oxygen, or CMRO2. And this is equal to the cerebral blood flow times the AVO2 difference. And I'll show you a reference how that can be measured through NIRS. So back when Ricardo and I started measuring this in stroke patients, the hypothesis was, could we use non-invasive NIRS as a surrogate for cerebral blood flow? So they're different units. That's important to remember. They're fundamentally different things to measure, but one could be a surrogate of the next. And the bottom one is really the delivery or carrying capacity of oxygen, the CaO2. And so the hemoglobin component in your blood is the biggest oxygen delivery mechanism. On the far right of that equation, the 0.003 is kind of a fudge factor based on the PO2, but your hemoglobin is a huge driver of the delivery. This is just to show you Tischauer's reference for that equation. And this is data, Ricardo, I went back and analyzed from our publication in the journal Neurosurgery. And the black dots represent the human cases of NIRS. And this was a very tedious experiment. What we did is we measured NIRS units right before we stuck them in the CT angioperfusion scanner, and then we delicately applied the NIRS numbers on the back end. They don't really make plastic NIRS catheters yet. And so the hypothesis really was that there are zones of brain oxygen on the y-axis, these mixed arteriovenous units, against the CT perfusion, so CBF. So two different things. On the x-axis, you have blood flow. On the y-axis, you have oxygen. So flow and oxygen. This was the hypothesis. We hypothesized it would be linear. There were some outliers you can see, like in the red dot, that we didn't really understand. We published that paper and we had to sort of defend it. And you can see in the bottom right, what you see is increased cerebral blood flow. And in the bottom, you see penumbra, that's salvageable brain. And this far left is the ischemic. That's a danger zone for the brain. You have 4 minutes, right? And we know that from ischemic modeling. And so this is the interesting part of using NIRS. And in the upper left, this is a dead brain zone, right? So if the brain tissue is dead, it doesn't extract oxygen. So your NIRS units are high, your CBF is low. So this was sort of the data. Maybe we'll get back and finally publish that. And this is just the same phenomenon to look at. This is what we don't want our patients to do. On the upper right, you want to have high oxygen and high blood flow. As you slide down towards zero, and there's data that we have from hypoxic piglet models that's been published in the Journal of Cerebral Blood Flow that shows this exact relationship. When you get down towards zero, that brain becomes dead, and then we'll have basically have a low OEF, or oxygen extraction fraction. So this is a dynamic issue depending on the brain state. Either the brain extracts oxygen, CMRO2, or does not, and it's OEF. So how does NIRS work? You have a NIRS light source, usually between 600 and 900 nanometers. the photons travel, you see in those two banana arc paths. On the right, what you see is a short detector and then a long detector. And so when we say that it's spatially resolved detection, what we're meaning is that some of the photons are measuring the scalp tissue, and the deep tissue is the deeper one. So you subtract those to understand what is the underlying brain tissue's optical density units. This was from a patient Ricardo and I had from a few years ago, just showing a commercial NIRS unit. So these go on the front of the head, and you can see that's a limitation. In the upper right, you can see on the left, that's the light emitter, the NIRS light emitter, and then the two light receptacles. And this just shows you the 600 to 900 nanometer range. Now this is an important normal graphical slide. And so on the x-axis, what you see is these are like medical students, basically with the jugular venous bulb, which is the blue line, the cerebral oximetry in green, and then the red is basically on arterial pulse oximeter. And what you see is in unison, if you make people hypoxic, they all go down together. But it's important to remember that cerebral oximetry is a mixed. It's about 70-30, so about 70% or 65% venous and 30% arterial. You can see the pulse oximeter on the hand is easier to isolate the pure arterial pattern. We can't do that yet with non-invasive cerebral oximetry. And I think NIRS has allowed us to prevent placing jugular venous bulbs. Those are like putting a central line, but you angle them toward the head. But you can see the utility because they're non-invasive. So they just
Mr. Powers, you'll notice that all of the sharks have laser beams attached to their heads. I figure every creature deserves a warm meal.
So, you know, that's the basis of this talk, right? We came here to talk about lasers. And the second point we're talking about is really summarizing the literature. And as I mentioned, we're really going to focus on stroke and subarachnoid hemorrhage. There's, if you look in PubMed, there's an explosion of other intraoperative monitoring in these, and even a carotid balloon occlusion test. A number to remember in that, when patients became symptomatic, the NIRS values dropped about 20% of baseline. So again, this is a trend monitor. This was just, Stefan talked about neurointensivists love geeky gadgets. This came out years ago when we did this study. This is in the journal Neurosurgical Focus, back when Phil Tosky was Ricardo's fellow, and we had a physicist, Bob Pulley, and others involved. But again, remember, NIRS is not cerebral blood flow. These are the established methods of cerebral blood flow, but we wanted to correlate the two. And so what I wanted to just quickly show you is on the limitations of NIRS. So in the upper left, what you can see is a hemorrhage in the right occipital pole, and there's that purple-blue bad-looking brain. Purple and black don't come back as often in the analogy. And this is not a good candidate for frontal NIRS, right? If you're monitoring the patches up front, you're not going to see that area, so that's a limitation. The next one below that shows a subarachnoid hemorrhage patient, and you can see that there's a little bit of right frontal oligemia. And then the third panel down shows you a lot of pneumocephalus. And so that patient, you're going to be measuring basically atmospheric air that got in there with a craniotomy. So we don't know what to do with that data. And you can see deeper in that second panel from the left, you see this big area of potential DCI or cerebral blood flow is reduced, that blue pattern. So you're not going to measure that deep. One other important number to remember is most NIRS light with spatial resolve go down about 2.5 centimeters. That's it. Now you can configure larger arrays, but you would need to probably shave the head. So that's an important practical limitation. So yes, laser beams, right? It's really cool. We're here on a Friday. We're going to move right along. And I wanted to share with you, I think probably the most illustrative utility of near-infrared spectroscopy in a practical case. So we received a 44-year-old man who is from the prison system, whereas one of our nurse practitioners said a friend from a gated community. He at 1 a.m. was yelling out to the guards an episode of incontinence and was left there for 5 hours. Interestingly, the guards really, I guess they thought he was playing possum or what have you. Anyway, he was finally brought, scanned, shown to have a subarachnoid hemorrhage and comatose, and had an EVD placed. So he was in handcuffs at the time. By that point, he was GCS 10. He was intubated and in handcuffs. He was able to move everything, so that was a good sign. You can see his vital signs were, again, this gets back to what Stefan said about the standard dashboard of panels. Nothing really horrible. He had a little bronchi, maybe he had aspirated. This was the CT scan. You can see that diffuse star-shaped pattern, a little bit more near his right midbrain and his EVD in place. He had a right PCOM that was coiled very quickly. The interesting thing is we didn't get a lot of history from the staff. And what I'll show you on the left upper image, he had a huge spleen and liver. And on the far right, that chest x-ray, the humerus has avascular necrosis. And in the bottom left, you can see he has cardiomegaly. So we're like, young guy, African-American, AVN, hepatosplenomegaly. So we kind of pieced this together and figured out he had sickle disease. Then he became progressive. He had hypoxic desynchronous ICP, hypotensive on nimodipine. So we gave him some mannitol, lined him up, and now we have to paralyze him. So it gets to the point where Stefan was talking about, things are fine on a sunny day flying a plane. Things are really terrible if you have a comatose or you have to paralyze a patient. The only thing you can do is check their pupils. So we hooked him up to quantitative EEG, and unfortunately his alpha delta ratio, as Jan Clausen and others were quite low. So that's not really good to trend from. And as echo showed, a high RSVP suggesting pulmonary hypertension. So we go through our ICP algorithm from the base up, manage his CPP, osmotherapy. Now he's paralyzed. You're left, you basically lose your neurologic examination. And at this point, the ICP was in control, but we don't have a neuro exam to see if he's going to develop vasospasm and DIND. We then put a PA catheter in him. I put the numbers there. You can see 22/8. So he had a normal and a normal wedge of 6. So he didn't actually have sickle crisis, and that was helpful. And this storm started developing too. So this is post-op day 3. He starts developing mild vasospasm on his right MCA, and he's in full-blown ARDS. We're bronching him daily. And again, we can't unparalyze him. So this brings up the utility of multimodal monitoring. Why should you care? Again, in standard flights, you need a few gauges: height, weight, temperature, blood pressure. That's fine for flying on a regular day, but you have to know what each one of the gauges mean. This is the cockpit of Shuttle Atlantis. And if you don't know, the escape velocity of Earth is 17,000 miles an hour. This re-enters the atmosphere, or did, at Mach 17. So it's extremely hot, and you gotta have lots of gauges. You gotta have precision flying. So the point being is that when you have very sick patients, you need more gauges, but you need to understand what gauges do. So at this point, I said, let's put frontal NIRS patches on them. And these numbers are staggering. The left, to give you an idea, normal NIRS numbers are like 50 to 80. Okay, they depend on optical density units, but that's just a normal number. It's like a catheter. So his left side was 20. His right was 9. It's the lowest ever reported in human history. Interestingly, his right TCD, I'll show you, was 220. So he was in severe vasospasm, and his sickle hemoglobin count was very high. So you have to apply your physics and physiology. This is his TCD showing severe right MCA spasm. Again, we applied the device. And this just shows you diagrammatically how it works, right? You emit the light and measure the photons, gives you these relative units. We talked about this already. And so this is the crux of this, and sort of near the end of the talk. Again, you have to go back to the delivery of oxygen, your cardiac output, and your CaO2 capacity. What's the problem with this equation? Hemoglobin. He's got a genetic defect of the oxygen capacity of his own hemoglobin. It sickles. So what did we do? We gave him 1 unit of blood, then talked with hematology, and they said, let's do an exchange transfusion. We gave him 11 units of normal hemoglobin A. We also injected intrathecal nicardipine to treat the vasospasm. And so what you see on the left upper image is this very asymmetric, very low bifrontal NIRS. what you see in the bottom right is these numbers snap into place, symmetry. They're both in around the 60s. We fixed him. And so this patient later woke up, we extubated him. He had some depressed effect. Of course, he was still in chains, and his buddies with Kevlar and Glocks took him back, but he survived.
Dr. Evil, it's about the sharks. When you were frozen, they were put on the endangered species list. We tried to get some, but it would have taken months to clear up the red tape.
You know, I have one simple request, and that is to have sharks with frickin' laser beams attached to their heads. Now, evidently, my cycloptic colleague informs me that that can't be done. Can you remind me what I pay you people for? Honestly, throw me a bone here. What do we have?
Sea bass.
Right.
They are mutated sea bass.
Really? Are they ill-tempered?
Absolutely.
That's a start.
So I would say there's limitations to using lasers in your ICU. Hopefully they're ill-tempered, or you can use the neurologic exam. It is non-invasive. I think can replace the jugular venous bulb. You have to apply supply and demand physiology. You have to think, do they have enough oxygen, oxygenation, cardiac output, and so forth. We've gone over those. There are benefits, but many limitations we reviewed. Also, NERS should be integrated into your dashboard with other components. And also, like any gauge, you have to be hypothesis driven. So if you're going to put a NERS gauge on, you have to know the normal values, say between 50 and 70, and then trend them. And I'll stop there. All right.
Why don't we use this more routinely for patients who are coming with spasm? I mean, not so much with spasm, but I know there was one great paper I can't pronounce. But what they showed was that, while it wasn't the most predictive for spasm, it was predictive for showing appropriate response to spasm. They actually found a correlation with infarcts and related to spasm with whether you actually resolve those numbers or normalize the numbers. And that, I think, is a bigger challenge. I think sometimes it gets spasm with these teams. That's not a harder problem. The bigger problem is when they're sort of comatose and oh, sorry. I overestimate my voice sometimes. So really the question was, why don't we use it to see if we are appropriately treating spasm? Because, we set hemodynamic augmentation goals all the time. We say MAP greater than 100 or cardiac index greater than 4. And we think it magically fixes the problem. Maybe in that patient, you need a MAP greater than 120. And probably having NERS on those patients, especially if they're comatose and you don't see a reliable, you don't have a reliable exam to go by, will actually tell you if you're hitting a metric that's clinically relevant. Otherwise, it's just an arbitrary number.
That's a great question, Raj. I think the first issue is awareness and adopt, more global adoption. I think a lot of people don't know when to use them or what particular indication. And for me, it's been a learning curve. I think the second question you ask is excellent because if you plug in NERS, you can do some Cambridge analysis to determine, are they autoregulated? Are they trending towards spasm? And use it in your management. But I don't know. I'm a fan of them. I don't use them on all my patients, but I don't know why other people don't use them more widely.
I mean, the case that you described, you've got, and Jan Klaassen has presented on quantitative EEG and alpha delta ratios, and I think Paul Vespa on relative alpha variability. The problem we run into, as you pointed out, is if they start off normal and then they become abnormal, they're very useful. If they start off severely abnormal, the 0.3s, 0.4s, they're garbage. I don't know what to do with them. So saying that they've now normalized based on some intervention you've done is impossible. Whereas perhaps with NERS, you don't typically start off, as you said, at 20 and 9. You might start off in the 50s, 40s, or maybe even 60s when you put them on. The other thing we've discussed, and we haven't really incorporated a whole lot because we now have NERS, we have the foresight, is using it for patients with carotid stenosis who are getting an endarterectomy or a stent, hyperperfusion syndrome. One of the reasons we think that hasn't caught on is because so very few patients have hyperperfusion syndrome. Of course, they have a bad outcome if they do, but you see it once, maybe every couple of years, whereas vasospasm we see all the time, and treating for vasospasm we do all the time. Great point.
I think it would be very interesting. It would be very easy to slide this on the IR before you open the carotid. And as you said, 110 to 140 minutes. It might be that this patient, again, you have a nerve at baseline of 60, now you open, now you go to 140. You could say, you know what, maybe this is too much. And use that to titrate to normal level.
Yeah, there was a Japanese paper that looked at that too. But again, small case series, for some reason, it's never caught on. Maybe it's something we should do as a group and probably study it a little bit more.
So we actually tried to look into this in the people that go for mechanical thrombectomy, where they have a CTA before and angio before, and it was NIRS plus ultrasound, but it didn't correlate at all. So I'm not sure if it's a device problem, if it's something else, but we didn't have any luck with that.
Yeah, we're finally going to be getting that neuroanalytics. They promised the next 2 weeks we're going to get that. It's going to be very interesting to continue DCT on these people. That's another thing that I'm looking for in this flying blind subarachnoid hemorrhage. Instead of doing once a day, you're doing every second. And they have all this algorithm of understanding what is below the curve. And so that's going to be very interesting with non-invasive added to the multimodal that you guys are.
Cool. Awesome. Thank you, Dr. Freeman.
Thank you, guys.
I've spoken enough. I'm going to let Dr. Hanel speak.
Sir talks a lot. Brave Hearts, I think this concludes our 5th year. A pleasure to have you here. I hope we can do this again. It's always a pleasure to have friends coming and visiting us and opportunity to exchange. Please make sure you send our feedback. We can only do better if you tell us the things that we didn't do well. Again, to the team, Wendy, Brian, Demetrius, and the list of names that Eric said before. Our industry sponsors and Baptist, thank you for making this possible, and we'll do it again next year. Thank you, guys.